Hello, everyone, and thank you for joining us for this very special day, especially those from the HypoPARA community joining us online and in person. Today is about you and for you. My name is Michelle Reyes. I am the Associate Director of the HypoPARAthyroidism Association and also a post-surgical HypoPARA patient who was diagnosed at the age of 23 after a total thyroidectomy from thyroid cancer. Our mission at the HypoPARAthyroidism Association is to improve the lives of those impacted by this disease through education, support, research, and advocacy. Today, we take another step towards that by sharing with you a better understanding of this complex endocrine disorder through this externally led, patient-focused drug development meeting. We hope you will gain a greater understanding of the severity of impact on patients' daily lives through the testimonies you will hear today. I would like to extend a special thank you to the members of the FDA who have taken the time to join us, especially the members of the CDER team we have been working with for the last year to prepare for today's event. Ethan, Lena, and Will, we appreciate the guidance you have given us. We know you are going to learn a lot from this incredibly brave group of people affected by HypoPARA and their caregivers who are sharing their experiences. We know you have many critical factors to consider on a daily basis, but we hope these presentations will help you understand the burden of this disease that is unfortunately growing in numbers of patients affected every day. I would like to welcome our sponsors who generously support us throughout the year, including today's meeting. Thank you to Amulet, Ascendis, BridgeBio, MBX Biosciences, and Takeda. The HypoPARAthyroidism Association was started in 1994, coincidentally the same year I was diagnosed. It was started by James Sanders, who himself, along with his 5 sons, all suffer from this disease. One of his sons, Bob, is currently the president of the association, and you will hear his story later today. James came up with the idea for the association after meeting another patient with the disease, besides himself and his children, while participating in a study at the NIH. Although much has changed in the 30 years since the association was conceived, one thing hasn't changed. We still do not have an FDA-approved treatment for hypoparathyroidism. What we have learned along the way is that HypoPARA is not just a lack of the calcium, even though currently that is the only part of the disease we treat. It is a complex endocrine disorder caused by no PTH or the lack of sufficient PTH. Long-term, the lack of PTH causes many issues with other organ systems such as kidney disease, cognitive dysfunction, brain and arterial calcifications, and other issues we are just beginning to understand. These organ systems are also increasingly affected by the only current treatment for the disease, which is large amounts of calcium supplements and active vitamin D. Today, you will hear about the daily burdens and impacts this disease has had on patients and their families. We are fortunate that researchers and the pharmaceutical industry have become very interested in HypoPARA over the past several years. There are currently 3 medications in clinical trials and several more in the works. Our medical need for treatment for HypoPARA is no longer just a dream. There is hope for our future and for future approvals, and we are so grateful to the HypoPARA patients who were desperately looking for help and have given of their time and bodies to be a part of these clinical trials. We are joined today by people from around the world affected by HypoPARA. So often we hear that your doctors don't understand and you feel unheard. Today is your day to be heard. Many of you will have the chance to share your stories and comments with us, the FDA, and other key stakeholders. We have so much to learn from your stories. Now, it is my great pleasure to introduce to you Dr. Naomi Lowy, Deputy Director of the Division of General Endocrinology at the FDA.
Thank you, Michelle. Good morning, everyone. As Michelle mentioned, my name is Naomi Lowy. I am an endocrinologist, and I serve as the Deputy Director in the Division of General Endocrinology in the Office of New Drugs and the Center for Drugs at FDA. I have been with FDA for almost 17 years, most of that time in new drug development for patients with endocrine diseases. I am very happy to see so many patients, caregivers, and advocates in the audience, and I know who are on the web as well. Thank you all for being part of this meeting and sharing your experiences with us. I would particularly like to thank the HypoPARAthyroidism Association and all of the staff that were involved in planning this meeting and for including us. Over the years, I have attended a number of patient-focused drug meetings, and I can tell you that hearing from the patient community has a profound impact on us. What you share helps us better understand how patients struggle and what they need, and therefore helps us drive, facilitate, and streamline drug development. I know we also have representation from industry, academia, and other medical product development stakeholders in the room and on the web. While FDA plays a critical role in medical product development, we are just one part of the process, and I am glad to see a high level of interest from those of you who also play an important role. These meetings give us and all of you key stakeholders an important opportunity to hear directly from patients, their families, caregivers, and patient advocates about the symptoms that matter most to them, the impact the disease has on patients' daily lives, and patients' experiences with currently available treatments. Hypoparathyroidism is associated with significant morbidity and poor quality of life. Just already speaking to some of you this morning, it is clear just how profoundly this disease impacts patients. The therapeutic options are limited. For many years, the only option has been calcium and vitamin D, often needed in high doses that are associated with effects on other organs. Parathyroid hormone was approved in 2015 as an adjunct to calcium or vitamin D to control hypocalcemia in patients with HypoPARA, but will be discontinued at the end of 2024. FDA recognizes the need for additional effective and safe treatments for hypoparathyroidism. FDA protects and promotes public health by evaluating the safety, effectiveness, and quality of new products, but we do not develop medical products or conduct clinical trials. It is, however, FDA's responsibility to ensure that the benefits of a product outweigh its risks. Therefore, having this kind of dialogue is extremely valuable for us because hearing what patients care about can help us lead the way in figuring out how to best facilitate medical product development for hypoparathyroidism and understand how patients view the benefits and risks of therapies for this disease. And we look forward to incorporating what we learned today into the agency's thinking. FDA shares the patient community's commitment to facilitate the development of safe and effective medical products for hypoparathyroidism. Once again, we are all here today to hear the voice of the patient. So thank you for your participation. We are grateful to each of you for being here and sharing your personal stories, experiences, and perspectives. Thank you.
All right, good morning, everybody. Thank you, Dr. Lowy, for that wonderful introduction. Michelle, fabulous job getting us kicked off this morning. So everybody, welcome. I am Patty Keating. I'm the Executive Director of the HypoPARA Association. And you'll hear me say HypoPARA a lot because hypoparathyroidism is that big, long word. So as we refer to it kindly as HypoPARA. So I'm a post-surgical patient as well of 9 years. And I'm happy I'm going to be the moderator for today's event. We've been working on this event for the last 10 to 12 months. Thankful for the FDA and their coaching and all of the sponsors. I'm going to review the full agenda soon, but before we get started with that, we have another special guest that we want to invite to speak to kick us off and talk about the effects and the symptoms of HypoPARA. So welcome to Dr. Michela Rubin.
Good morning. It's a pleasure to be here today to speak at this externally led, patient-focused drug development meeting. These are my disclosures. HypoPARAthyroidism is a rare disease, the hallmark of which is a low serum calcium in the setting of an absent or low PTH level. It's a very rare disease. Estimates say that it's present anywhere from 77,000 to 115,000 people in this country. And the most common cause is post-surgical hypoparathyroidism, which can happen after anterior neck surgery, maybe for thyroid cancer or goiter or hyperparathyroidism. But 25% of patients have non-surgical hypoparathyroidism, and this can include genetic causes like autosomal dominant hypocalcemia type 1, autoimmune polyendocrine syndrome type 1. There can be transient hypoparathyroidism in the setting of low magnesium, other autoimmune causes, rarely destructive causes. And what happens when we don't have enough PTH is that the mechanisms for controlling calcium and phosphate become deranged. So PTH normally will liberalize calcium and phosphate for the bone, thus raising serum calcium. It will also promote the reabsorption of calcium at the level of the kidney, thus raising calcium. At the same time, it will help with phosphate excretion at the kidney, and at the kidney, PTH stimulates the conversion of regular vitamin D to activated 1,25-dihydroxyvitamin D, thus promoting calcium and phosphate absorption in the intestine. So without these mechanisms, people are left with a low serum calcium, a high urine calcium, and a high serum phosphate level. And to try to address these, patients take conventional management, which means taking calcium pills multiple times a day, as well as calcitriol or activated vitamin D, since the body isn't able to make it, multiple times a day. And in addition to those pills, patients often need to take pills for low magnesium. They also need to take regular vitamin D pills and sometimes also thiazide diuretics to help combat the hypercalciuria. And together, this leads to a very heavy pill burden. And that, along with the symptoms and the long-term complications, lead to a substantial burden of disease. And physical symptoms are very common in patients with hypoparathyroidism. Most of them relate to neuromuscular irritability. So patients will very frequently describe struggles with muscle function, so muscle twitching, cramping, spasms, or weakness. More than 80% of patients describe tingling and numbness, and then there are nonspecific features also like fatigue, low energy pain, or heat intolerance. And when hypocalcemia is severe, more dangerous symptoms can happen. The EKG can show prolongation of the QT interval, triggering an arrhythmia. Patients can even have seizures or life-threatening laryngospasm. And conventional treatment really isn't adequate for treating these symptoms. First of all, because we oftentimes have wild swings in the calcium with erratic biochemical control. So patients can have symptoms of hypo and hypercalcemia with conventional management. And also, we're limited with how much conventional management we can use, because were we to give our patients enough calcium so they could function normally, it would be at a cost to the kidney by increasing the hypercalciuria. Cognitive symptoms are also very common in patients on conventional management. Over 50% of patients say they have brain fog, and what this means more specifically is memory loss, forgetfulness, trouble concentrating and focusing, trouble understanding information, difficulty with finding the right words, impaired ability to have a conversation. And again, these symptoms are often present even when the serum calcium is normal. So it's also not being addressed by conventional management, and it raises the question of whether the PTH itself is important for normal cognitive function. We know that PTH crosses the blood-brain barrier, and it binds to CNS neurons that have a PTH receptor. So this might very well be an important facet of hypoparathyroidism that will be not addressed at all, even when the serum calcium is normal on conventional management. Emotional symptoms are also a big part of hypoparathyroid patients' lives who are on conventional management. Large epidemiologic studies have shown that the risk of suffering from psychiatric illness is more than doubled in surgical and non-surgical hypoparathyroid patients. So this can entail feeling depressed, and a very large systematic survey showed that depression is one of the most common complications of hypoparathyroidism. And patients live with anxiety. They might be afraid of the future, being able to take care of themselves, their family, and being able to continue to work. They also live in fear of having a calcium crash, which is when the calcium suddenly drops and patients have sudden physical and cognitive symptoms and need to go to the ER or be hospitalized. And these crashes can happen completely unexpectedly without an obvious trigger. Patients also worry about the long-term consequences, problems such as kidney stones, kidney calcification, and chronic kidney disease. And not only does conventional management not address those complications, it actually worsens the risk of those complications. And patients also worry that their caregivers are just not understanding their difficulties. Over and over they will hear, but everything is fine, your serum calcium is normal. So overall, these emotional symptoms are really not being adequately addressed with conventional management. And taken together, this constellation of physical, cognitive, and emotional symptoms leads to a degraded quality of life for hypoparathyroid patients. Multiple studies in multiple populations have shown that patients live with poor quality of life with hypoparathyroidism. General nonspecific tools like this short form health survey 36, as shown here, has shown that unconventional management patients suffer with reduced physical and mental function. And more specific hypoparathyroidism surveys that are tailored for hypoparathyroid patients have shown the same thing. And again, these surveys were mostly done with patients who have normal serum calcium, showing that even with normal calcium unconventional management, quality of life is severely compromised. What this translates to people is really debilitating issues in their personal and professional lives on a daily basis, which means that many patients have symptoms for most of the day despite being on conventional management. Many patients have to plan around the fear of having symptoms when they plan out their day. Despite conventional management, patients are burdened with multiple pills. Some patients take upward of 20 pills a day. Patients on conventional management don't have full mobility, are limited in their activities, being able to exercise. They're limited in their activities at home, feeling they can be able to take care of their children without counting on someone else. And patients on conventional therapy also might not have full productivity at work and in fact might even be worried about their job security because their disease isn't being sufficiently managed. And perhaps most importantly, this affects interpersonal relations of patients with their family members and loved ones, and also can thus very adversely impact their social relations. So I think it's abundantly clear to us that the poor quality of life and the symptoms in this disease are not being adequately treated with conventional management, and we urgently need new treatment strategies in order to be able to improve the lives of hypoparathyroid patients. Thank you.
Great. Thank you, Dr. Rubin. That's amazing, as usual. All right. So today is really about the patients and the caregivers. Everything we talk about today is going to be about your experience, what you're living with on a daily basis. And we're so grateful for, our pharmas to be here, our clinicians, our researchers, people all over the world. But our number one ground rule for today is that it is about the patient and the caregivers. So we want to hear from you as we go through the day, whether it be in person or whether it be online. And Michelle will read out some of those. The second ground rule is this can get a little personal and a little emotional. So we ask that we respect that as we go through the day and know that as patients it's okay, and we'll take the time to get through that. The last rule of the day, which I kind of thought was kind of fun, that I am the only one that gets to ask questions. So I'm going to ask you guys questions, and you guys get to respond. So as we go through the day, we're used to patients and everybody being able to ask questions, but this is a very structured format. We want to get through the day to really get these 13 people and their stories out, as well as the people online. So we're looking forward to that. The last rule is that we ask that you refrain from speaking about insurance, how much it costs, clinical trial design. The FDA really can't help us with that piece of it. So it's really about how are you living day to day with HypoPARA.
So for people online, also, the next 30 days, it's going to be open for you to put all the comments in, and we have a fabulous medical scientific writer who is going to be capturing all of those comments to be able to write a great report for us that'll be available later in a couple months. So let me talk about how today's going to go. So we're going to do a lot of polling. I think in the community, we've talked to everybody about that. As we go through, we want to hear from you, patients and caregivers, around your symptoms and things like that. So we'll go through that. We're going to do then we'll go out then we're going to have the panelists speak. We'll have this group of panelists speak about symptoms, and then we'll actually take a lunch break for about an hour, and then we will come back and we'll do it again in the afternoon. But in the afternoon, we're going to talk about current treatments and future treatments. So on your table, if you're here or if you're online, there's a QR code that you can log on to sign up for our polling. And we're going to go ahead and get started with that. All right, so our very first question is, everybody ready? Are you A, someone living with HypoPARA, or B, a caregiver of someone with HypoPARA? Fabulous. It looks like we have a lot of patients here, and we also have the lovely support of our caregivers as well. Give it one more second. All right. So it looks like definitely a lot of people with HypoPARA. We thank you for tuning in. And now we're going to find out where you're tuning in from, right? So where do you currently reside? The answers are A, U.S. Pacific Time Zone, B, U.S. Mountain Time Zone. Are we on to the next polling? C, U.S. Central Time Zone, D, U.S. Eastern Time Zone. I'm sorry, E is U.S. Alaska Time Zone, F is U.S. Hawaii Time Zone, G, Europe, H, Middle East, I, Asia, J, Canada, K, Mexico, or L, Central or South America. Where do you currently reside? Give it just a few minutes to pull up. All righty. Looks like we had a lot of people get up early this morning in the Pacific Time Zone, Mountain Time Zone, and of course right here on the Eastern Time Zone. And thank you for those that are probably in the middle of the night over there in Europe. Very good. All righty. Great. All right, a little bit more Europe's happening. In Canada, welcome everybody. Very good. All right, so the next question is the person living with HypoPARA female, male, or other? A, female, A, male, B, female, C, other. All right. And as expected, a lot of female. We know our population is heavy on the female side. All right. Next question. How old is the person living with HypoPARA? A is 0 to 10 years, B, 11 to 18 years, C, 19 to 35 years, D, 36 to 55 years, and E, 55 years or older. And again, we're in that kind of expected age group there of 36 to 55. And we do have some of our youngsters here as well today. You're going to be hearing from them. 11 to 18s, 19 to 35. And I think I'm in that E category as well. Us 55 or plusers. All righty. Okay, so that's how our polling is going to go today. So thank you so much for participating in that. We have polls throughout the day that will actually set up questions for the afternoon. Now, we're going to take a little time to hear from each of our panelists. And again, these guys are going to talk mostly about symptoms, but they're going to talk about the effects that HypoPARA has had on them. And we're going to ask them to continue on. I'll just introduce their name, and we're going to continue on all the way through. Then we'll open it up for a discussion. We'll do some more polling, and then we'll open it up for discussion from there. So our very first presenter today is Andrea, who's a post-surgical patient. Andrea?
Good morning. So I'm Andrea. I'm from Indianapolis. And I first realized I was in serious trouble 3 days after my total thyroidectomy, the day of my first ambulance ride. My children, then 5 and 7, watched as I was wheeled nearly unconscious out of the house. It destroyed them. Thankfully, I don't remember much. After I was discharged, my eyes were puffy, I was still shaking, and I was a complete wreck. At this moment, I realized this calcium thing was likely going to be a problem, but what I didn't recognize that my life as I knew it was completely over. Like a lot of patients, I had to watch the woman I was slip away, the strong, self-sufficient woman who became a healthcare executive before she was 40 was now frail, insecure, anxious, and simply exhausted. She went from fierce to powerless in 1 week's time. The woman who wouldn't let anything stand in her way was now someone her colleagues and her family were fearful of. She was no longer independent, but now dependent. She's gone, and I still grieve her. I will always grieve her. And I know she'll never, ever return. This disorder was hard on my overall mental health. Every time my calcium fluctuated, my body would go into a fight or flight response. My heart raced, and I was sure I was going to die. It was paralyzing, but now is a warning sign that I recognize. I never appreciated how debilitating anxiety was and that people really do not have control over it. My family watched me struggle, but learned my cues. When I'm going low, I do what they call birding, which is where my eyes are open wide and I look around with force. When I'm low, my voice quivers. It's something I can't notice, but those around me do. And I hate the quivers because it makes me feel weak. It's a fault that others can see in me, but I can't see in myself. In the early days, I did not take care of my mental health because I didn't understand the constant state of fight or flight, the impact that has on the body. I found a few drinks at night would calm the anxiety, and I'd be able to sleep, finally. Very quickly, the amount to calm my anxiety increased, and I became dependent. I replaced anxiety with addiction in the blink of an eye. I went from a high-achieving woman to rehab in 1.5 years. More traumatizing events my children and my husband had to watch unfold. Once I was completely defeated and beaten into submission, a new woman surfaced. I keep a blood pressure cuff at home so I can check to see if my calcium levels are low enough to require a visit to the ED or if it's something that I can manage to fix with the liquid calcium citrate I keep in the fridge. Every outfit I wear incorporates a belt because in a pinch, a belt works just as well as a blood pressure cuff. I have journals to write in because I can't count on my memory anymore. Yet another defeat. I've learned to use labs located only within a hospital that does not outsource their laboratory operations so that I can get my results in 30 minutes to an hour through an online portal. Thanks to the Cures Act, I don't have to wait for a doctor to tell me what to do. I fix it myself. I learned to talk reasonably and without emotion with the emergency room staff. When they are hesitant to dispense calcium, I ask them questions like, how many people walk through your doors fiending for calcium? What harm would come from infusing a non-fat soluble mineral? I remind them I'm not asking for pain meds and I'm not asking for controlled substances. I am begging for calcium gluconate. I learned to only use one local emergency room so they know me as a patient. When I'm traveling, I now explain to the staff what will happen in a calm way that's not threatening to them, but more informational. While you wait for my labs, I will become very confused. The tetany will spread to my face and my larynx. When that happens, I am a seizure risk, and I will be very, very afraid. I figured out the nurses are my best friends. They truly know what is going on in that ED, and they have been some of my best advocates over the years. I developed, and I always carry a how to help me document, along with a 2-page summary of all of my medications, conditions, and the information the clinicians need, and I walk them through my care. I choose to stick to a very stringent medication schedule as well. I take the same 29 medications and pills, tablets, at the same exact time every single day by alarms on my phone. I no longer have the luxury of sleeping through the night because I set alarms to take meds at 1 a.m. and 3 a.m. to space them apart from my calcium. I eat the same food every day because I learned consistency and predictability make this disorder more manageable. In early November, I attended the National HypoPARA conference, and I ate the conference food instead of my normal diet. After the conference, I boarded a 6-hour flight headed to the AAMC meeting in Seattle. I was working on my computer when my heart started racing, and I got that dreaded feeling of imminent doom, and I knew I was crashing. I went into tetany, and I had 5 hours left on that flight. I was terrified, and I knew I was in immense danger. I gave the flight attendants my how to help me documents, and then I had them open my emergency kit for me. The flight crew were afraid, the other passengers were nervous, and I was certain I was either gonna die or I was gonna go viral for causing a flight diversion. Both options were less than ideal in my mind. There's no room for error in this disorder. I did not stick to my plan, and because of it, I put my life in danger. This is no joke. Even for those that have 6 years of experience, we still get it wrong. What I've learned is it's very important that we seek support as we navigate this disorder. It's hard on us physiologically, and we can't think our way out of some aspects of this disorder. As difficult as it is on us as patients, it's even harder on those around us that have to watch us learn to cope with the disorder. My children have long-term implications from what they saw, and my husband will never be the same, and neither will I. The tables have turned, and my children now put me to bed every night before I turn into a pumpkin, they say, and they also help care for me in other ways. I'm always on their mind, and it shouldn't be this way. I'm their mom. I should be taking care of them. I recognize that now I'm strong in different ways, and I have a little bit more empathy. But I know I'll always grieve the woman I was before. I can't forget her. This new woman I was forced to become is holding her own, but her body's tired, and it keeps getting harder. So we need to make things better for those who come after us.
Thank you, Andrea. Okay, now we're going to hear from Anna. Anna is a caregiver and mom to Amelia, our idiopathic patient.
Good morning. My name is Anna, and I am privileged and honored to be mom of Amelia. Amelia had just turned 10 when she had her first seizure. She had a calcium level of 5.4, and not the ER doctor nor her pediatrician thought anything was wrong with that. She had a second seizure a month later and was referred to a neurologist. She was diagnosed with epilepsy and put on anti-seizure medication for about 3 months. During those 3 months, we'd find her in bed with severe leg pain, stomach cramps that made her hunch over with pain, tears coming down her eyes. Her skin behind her knees was dry and peeling. Her nails were brittle. And if she ran too much, she would become short of breath and became dependent on an inhaler. What was happening to my little girl? Not until her 3-month follow-up did her neurologist question her calcium levels. So blood work was repeated, and we were sent to an endocrinologist. She was then diagnosed with idiopathic HypoPARAthyroidism. What was that? How do I help her? I knew nothing of my daughter's new diagnosis, and no one around me had ever heard of it. When she was first diagnosed, her endocrinologist said she just had to take vitamin D and calcium on a daily basis. Didn't make it a big deal. He told her to take Tums and calcitriol, and that was it. We were told that if you regulate her calcium, she'll be fine. That's not how it works at all. People with HypoPARA have so many other symptoms, and even when her calcium is quote-unquote normal level, she is anything but fine. It's been almost 5 years since her diagnosis, and we've learned so much. We've learned all about the delicate balance we need to have, watching all of her electrolytes, not just her calcium, but her magnesium, her phosphorus, her potassium sometimes. No one told us the effects this would have on her kidneys or how tired she would be, or that as she grew and went through puberty, it would make it worse. We've been to the ER several times, at least 3 or 4 times a year, for a calcium level blood check, as there are no home devices available or any other reliable means for knowing how low or high her calcium is. And if she's too low, will she have a seizure again or have difficulty breathing from going up the stairs at school? Do you know how much ER visits cost? I am well aware each visit is at least $1,500, and that's with insurance. And there's medications, plus lab work every 2 or 3 months, sometimes every week if she's not feeling well. And doctor visits, lots of doctor visits. We have an endocrinologist, a pediatrician, a stomach doctor, a blood doctor, a kidney doctor, a foot doctor, a psychiatrist, a nutritionist, and a therapist. But we do it all, because when it's about your child, there is no price tag. There are no limits. She has missed so much school and social events from the fatigue that shows up uninvited at any given moment. Last school year, she was crippled with anxiety that sent her for 2 weeks to a behavioral hospital. Out of 180 school days, she missed 45 days. We were sent to court for her absences and had to put her under a special program. She struggles to complete assignments due to brain fog and inability to focus. We miss family functions, social events, meetings, and gatherings of all sorts because she is tired, anxious, or not feeling well. She cries because she wants to be normal. She is a teenager that should be social, active, and participating in extracurricular activities. She tries. She signs up for swimming, volleyball, band, wrestling, but doesn't make all the practices or the games or competitions. Her fatigue doesn't allow her to keep up with her peers. She cries, gets frustrated and angry, and we watch all this. We plan vacations around doctor's appointments and blood works. We carry doctor's orders with us and extra calcium everywhere we go in case she starts to feel low. Even this trip had me planning and packing months in advance. I worry about her every day, all the time. Are her calcium levels well today? Will her energy carry her through the day? Are we giving her too much calcium or too little? It's a lot to take care of and think of on a daily basis. We hope and pray that as she goes into adulthood, there will be better options, better treatments, better outcomes, and an improved quality of life. She has always been a fighter, and she continues to fight, and I will continue to fight with her. Thank you.
Thank you so much, Anna. All right, so Amelia, looking beautiful today. You ready to share your story? All right, Amelia is our pediatric idiopathic patient.
Okay. Good morning. My name is Emilia Garcia. I'll be turning 15 in April, and I've been battling with hypoparathyroidism for 5 years. In 4th grade, just after my 10th birthday, I went to my sister's room to rest after an abnormally tiring day at school. Little did I know I had my first seizure that not only traumatized me, but my sister. That was my first and unfortunately not my last ER trip, full of never-ending tests, scans, and being pricked by needles to the point of bruising. Somehow doctors discharged me when my calcium was at a 5.4, when the normal is an 8 to 10. My hypoparathyroidism wasn't diagnosed until my second seizure and 3 months on being on epilepsy medication. Knowing what was going on didn't help. It just meant I had to do blood work every 2 weeks and take dozens of different medications. My mom would call them vitamins to try to make me feel better, but other people don't end up in hospitals if they don't take theirs. I felt so alienated when I realized my classmates didn't have to take a cup of meds every morning just to survive the day. I would go to the point of throwing away my meds every morning just to survive the I would go to the point of throwing away my meds every morning just to feel normal. Knowing I was just hurting myself. Having to explain to my friends why I had to watch what I ate, take medications with my meals, and why I constantly missed school made me feel like a burden in a charity case. They knew something was wrong with me, but didn't know how to help. Knowing no one around me knew what I felt or what I was going through isolated me. No one knew what it was like to miss out on holidays because I'm stuck in a bed because my arms are hurting and my legs won't let me get up, or leaving sleepovers early because my calcium's too low and I'm going to start to crash. This disease has not only taken over my physical health, but also my mental health. A mess of missing my parathyroid hormone made a suffocating cloud of depression and anxiety over my head. I remember having a panic attack on the school bathroom floor. My hands, legs, and even face was cramped up because my calcium was so low. I couldn't move or even talk, so my best friend tried to understand my mumbling to unlock my phone and call my mom. I had to see her freak out and race against the time to either get me somewhere safe or have another episode. Isn't something HypoPARA patients, caregivers, or I should have to worry about. I wouldn't hurt myself trying to find an escape. I didn't want to be alive. I never thought I'd make it to my 13th birthday, let alone my 15th. If all the diabetics are able to have hundreds of options for treatment, why can't we? I refuse to take handfuls of medication every day just to live a normal life.
Thank you, Amelia. Very brave. Thank you. All right, our next patient panelist that's going to speak is Miranda, and she's a post-surgical patient.
Good morning. My name is Miranda, and this is my story with HypoPARA. When I was 12 years old, my life changed forever. My mom took me to the pediatrician for a lump on my neck. The lump was large, and so the pediatrician referred us to a pediatric surgeon who stated I had a goiter that needed removal. The pediatric surgeon did not discuss the risk of something like HypoPARA happening to me. I was quickly booked for surgery to remove the goiter and half my thyroid. No ultrasound, no biopsy, no further testing was completed. I remember feeling very anxious and very scared about the surgery. The surgeon called my mom during surgery and gave her 10 seconds to make a potential life-altering decision. The surgeon said the thyroid looked suspicious and recommended a full removal. The surgeon explained it would be riskier to complete a second surgery than to take the whole thyroid that day, and I would simply be on a pill the rest of my life, but would live a normal life. My mom consented. Hours later, I woke from surgery, confused and helpless. My vocal cords had been cut, and I could not speak much. By the end of the night, we quickly noticed something was very wrong. My body felt off, and I was having strange symptoms. My symptoms progressed, and I was moved to the ICU. Nobody seemed to know what was happening to me, and I was terrified. The surgeon did not include in the operative report damage to my parathyroids. I remember the surgeon and endocrinologist fighting and arguing outside of my room and how worried it made me feel. It took weeks to figure out my calcium levels, many infusions, and upwards of 40 to 50 times a day. I was later told a complication occurred, and I now had HypoPARA. The endocrinologist told me I would be okay, but would need to take calcium for the rest of my life. But no one could tell me what my future would hold. I spent the next several years fighting my way through school. I was placed in special education classes due to being unable to read or complete simple math. It was almost like my brain was no longer working after my surgery. I could no longer think, could not retain information, and I struggled to concentrate and hold simple conversations. I was told I was lying and faking it. I was sent to a psychologist who told my mom I was doing it for attention and possibly had PTSD. To cope, I stopped eating and developed an eating disorder. My life felt out of control. The first few years after my surgery, I spent my time going to appointments, lab draws, and had countless hospital stays for infusions. I could no longer dance, play volleyball, sing choir, or hang out with my friends like a normal teenager. My life consisted of around-the-clock calcium monitoring, including middle-of-the-night wake-ups due to muscle cramping, tingling, twitching, and other symptoms. The only option was to take calcitrol and calcium supplements. It took over a year for doctors to figure out my body was not absorbing calcitrol pills, and I was switched to the liquid form that costs upwards of $1,000 a month. My mom would later go on to file bankruptcy due to the medical debt incurred from my HypoPARA. Many school days were spent in the counselor's office crying because I could not function in class, or leaving to get labs where I was told to go back to the hospital for more IV infusions. My life was consumed with these blood draws and trying to figure out when and how much calcium to take to stay alive. Currently, there's no way to check calcium except to go to a lab or an ER. I spent the next several years taking life one day at a time, doing my best to try and live while battling a rare invisible health condition. I went on to start college, get married, and have 2 children. My journey to pregnancy and motherhood with HypoPARA was excruciating at times. My HypoPARA affected my labor, stalling my progress 3 times for several hours over the course of 3 days before my daughter was born. After my daughter was born, the OB discharged me even though I told him I was not okay and needed labs. I remember having to leave my daughter with her dad in the hospital room while I walked down to the outpatient lab in my socks to wait for labs. I remember feeling embarrassed and humiliated. While pregnant, I had home infusion and had over 150 IVs placed and daily bags of IV fluids just to make it through. I was forced to work from home in between lab draws, appointments, and infusions. My babies were born with abnormal calcium levels, and the entire time I breastfed, their levels would mimic mine. I spent hours taking my daughter to endocrinology appointments and lab draws, only to be told they did not know why her calcium was fluctuating. I felt angry that HypoPARA was impacting my child now. 6 weeks after giving birth to her, my calcium rose to a critical level, and I was rushed to the hospital after collapsing in the living room. I told my husband I was dying. It took several bags of IV fluids to bring my calcium levels down, and was discharged home only to crash again days later. I later learned that breast milk can impact calcium levels. As emotional as it was, I quit nursing my daughter to hopefully stop the roller coaster of low and high calcium fluctuations. My heart was broken, my body failed me, and I felt like I was failing my daughter. After having my son, I remember trying to go to the lab when my body was crashing and being unable to buckle my kids in and out of their car seats due to tetany in my hands. Unfortunately, I have learned that with HypoPARA, any change you make in life can cause a detrimental effect to your calcium level without you even knowing it. Stress, lack of sleep, exercise, temperature changes, and simply existing can cause these fluctuations. I'm now 31 years old, and for 19 years, I've felt invisible and misunderstood. I constantly have to change plans and miss out on important things. I feel chained to my condition at times, and it keeps me from living the life I want to live. My life has been defined by what others think my condition is, not what it actually is. This condition at times feels invisible, isolating, and like there's no way out. It's impacted my entire life, from relationships to jobs to my children and to my overall health. It's hard to not think about how my life could have been very different if the surgeon and physicians were more educated.
All right, thank you so much, Miranda. We're next going to hear from Julia. She is a patient with APS1 HypoPARA.
Hi, my name is Julia. I've been managing autoimmune HypoPARA since 1983 as part of a rare genetic disorder called APS type 1. APS type 1 includes 3 classic manifestations, one of which is HypoPARA. The other 2 are Addison's disease and candidiasis. I have a combination of disorders with APS type 1 that complicate my HypoPARA management. It highlights the importance of improvements needed in treatment. I was 3 when I exhibited my first hypocalcemic seizure. Unfortunately, I was misdiagnosed with epilepsy. Most clinicians are unfamiliar with APS type 1, and affected children often present, as I did, to the emergency room with seizures due to severe hypocalcemia. They're often misdiagnosed with febrile seizures or epilepsy. As a preschooler, I continued to have seizures, laryngospasms, and then I developed cataracts. At the age of 5, so this is 2 years later, an ophthalmologist found the cataracts in both of my eyes and connected the cataracts to the past years of hypocalcemia. My best visual acuity at that time was 20/80 in each eye. The calcium deficiency had taken its toll. The ophthalmologist referred me to an endocrinologist who would then help to put the pieces together. Finally, I was diagnosed with HypoPARAthyroidism in 1985 at the age of 5. Finally, I began treatment for HypoPARA with calcitriol and calcium, the standard of care. This was the 80s. My cataracts were significant. The ophthalmologist had to remove both of the lenses in my eyes, so I now wear contacts and glasses, both, to achieve 20/25 vision in both eyes. Without these corrective lenses, I am legally blind. So as a child, I managed HypoPARA. I managed them with the other autoimmune disorders that I would develop. This was complicated. Until recently, I managed HypoPARA only with the standard of care, calcitriol and calcium. This medication was adequate. It doesn't replace the parathyroid hormone, though, with this disorder. It's the only autoimmune disorder that I have that does not have a direct hormone replacement. I often had varying high or low calcium symptoms, even while on the medication regimen. High levels caused increased urine output as calcium spills into my urine. This would show up in childhood as bedwetting. It's very humiliating and embarrassing. It showed up as incontinence. It showed up as kidney stones, and it increased my risk of further kidney stones. Low levels would cause other debilitating symptoms: numbness and tingling in the hands and the feet to varying degrees depending on the level, decreased muscle strength. This inhibits physical activity, as you've heard, altered mood, irritability, brain fog, difficulty concentrating, and then as they got more severe, you get the tetany, and that's painful. You can imagine what those symptoms, how they affect your life, including difficulty walking, climbing stairs. Into adulthood, it was difficulty carrying my children, carrying anything. Accomplishing tasks with efficiency that require concentration was also difficult. So I try to be proactive. I try to manage my highs and lows. I try to prevent the severity, the extreme swings. I get outpatient labs when I notice symptoms start to appear. I adjusted my medication at home when possible. I couldn't always avoid hospitalization. Wide fluctuations can still occur with standard of care. My lowest level was 4.8. My highest level has been 13.0. Those are extreme, and those are very dangerous. Managing HypoPARA with other autoimmune diseases, as I've said, is complex and it's difficult. I'm not above a challenge. I will do everything I can to manage this. I was often hospitalized with hypocalcemia when I would acquire upper respiratory infections, stomach viruses, bacterial and viruses. Any trauma or stress to the body requires additional steroid management for Addison's disease, which I also have. This steroid management further has an unintended consequence of lowering my calcium as well. Calcium absorption was then hindered after a diagnosis of pernicious anemia, another autoimmune cause for that. Gastritis would ensue during my 20s. This would also affect my absorption of calcium. The gastritis is what is thought to have led to my stomach cancer in 2013. The removal of my stomach in 2013 also hindered my calcium absorption. So you can see how this is all complicated. I continued to face even more difficulties absorbing all of my medications, but specifically, I didn't absorb calcium or oral calcium well. These require acidity. They also require a stomach. I don't have that. Between 2013 and 2015, after my total gastrectomy, while still on the standard of care, calcitriol and calcium, I was hospitalized on average 4 times a year, weekly hospitalizations, due to critically low calcium. This oral medication regimen was not ideal. It continues to miss the mark, but it was all I had. It was my only option. I've lived my life with this mediocre management because I had no other options, until HypoPARA came out in 2015. When I began using HypoPARA in 2015, it was life-changing for me, life-changing for my family. I know what my quality of life can be like now. The wide fluctuations have ceased. The symptoms are not as severe. My quality of life is drastically improved. I could explain more, but I'll leave it at that. I'm still on HypoPARA right now through a compassionate use program. It will be done at the end of 2024. I do not want to go back to standard therapy. I don't want to average 4 hospitalizations a year. These are the acute symptoms that I feel every day that I've talked about, but there are long-term symptoms as well. I've had HypoPARA for 40 years. So the standard of care and the disease have taken its toll. They cause unseen damage to the body. My bones have significantly weakened over the years, as evidenced by DEXA scans. I now have osteoporosis. A simple fall leads to a fracture. This occurred in January. I fell and broke my wrist. 2 bones broken, required surgery. My kidneys have been taxed with calciuria, so they're showing signs of damage. My body is full of calcifications, even in my brain. While the window to build bone has passed, I still have power. I have power to slow the decline of bone. I have power to limit the calcium that spills in my urine. I have power to seek help. I have power to implore you to research direct parathyroid hormone placement. I have power to push for the therapy that I need and others need. I need this rather than the standard of care of vitamin D and calcium. Those with APS type 1 that are diagnosed with HypoPARA at an early age and have a full life ahead of them need hope that there are health outcomes that are better than we have achieved in the past. They don't need to fear long-term health effects of poorly managed calcium. Thank you.
Thank you, Julia. The rare of the rare just gave us some really great details around APS1. Thank you so much. And our final presenter for this morning is Kimberly. She's the caregiver for idiopathic HypoPARA patient.
Hi, everyone. Thank you so much for being here. My daughter Ellie was diagnosed with idiopathic hypoparathyroidism at age 8 when we wound up in emergency after her hands completely spasmed shut. We were blindsided. We were sent home with an order to take a ridiculous number of Tums and calcitriol, stating that that was all she was going to need to live a normal life. But that was wrong in so many ways. Every day became a battle. The Tums made her stomach hurt, and she refused to take them. Her calcium dropped, and we were back in the ER. We were switched to calcium carbonate capsules, but continued to have issues with compliance, stomach aches, headaches, spasms, fatigue, and paresthesia. The years have brought us to immediate care centers in the hospital several times. Finding a knowledgeable provider is very difficult. We've been dismissed many times by multiple providers, stating that her complaints of pain, fatigue, and general malaise could not possibly be related to her condition. But it is, all of it. What many physicians don't seem to understand is that even though her levels are considered stable most of the time, her quality of life still isn't good. Being constantly ignored is so frustrating that she has stopped telling the doctors, and me, when she's having pain. She states that she's used to it, and we can't do anything to help her anyway. A child should never be used to having chronic pain. No one should. At age 11, she began complaining that she couldn't concentrate in school and was having difficulty remembering information from class. Her grades slipped, and I missed the signs. With tears running down her face as she experienced paresthesia and laryngeal spasms resulting in labored breathing, we were back in the hospital. We switched to calcium citrate, hoping for better absorption, but the amount of pills was daunting. No child should have to take up to 15 pills a day. In the little over 4 years since diagnosis, she has taken over 18,000 pills. If that doesn't shock you, it should. It's unsustainable, and it directs our entire lives. We are constantly counting out pills, watching the clock, planning our entire lives around when she needs another dose, because if we miss one, it can be very difficult to pull her levels back up. We look for hospitals that are close by when we're planning vacations. We don't dare attempt international travel. There's a constant level of stress and worry that affects our entire family dynamic. There are no carefree or unplanned days. It's not just calcium. We have to monitor her levels of multiple things. It's virtually impossible to keep her levels of everything in the narrow ranges that are required for regulation, and she suffers because of it. New issues arose as a direct result of the amount of calcium that she's forced to take. Her kidneys started to struggle. She's had kidney pain several times due to probable kidney stones. Have you watched your child hunched over, clutching their side and crying in pain? I have. I cry with her because there's nothing else I can do. I hold her hand and try to distract her with funny videos during the blood draws that she needs at least monthly. I negotiate, I threaten, I beg, and I plead to try to get her to take her pills, to drink the right amount of water, to make the food choices she's supposed to make. I watch as her childhood slips by. She's too tired to play, to try out for sports, to run around outside with her friends, to just be a kid. She's old enough to understand what her condition is and to feel scared and alone. On hard days, she says she would rather be dead. Those words hurt me through the depth of my soul. I'm failing her. We are failing her. I can't fix this, and as a parent, that's the hardest thing to accept. There have been some positives. My beautiful daughter is stronger than I ever would have realized without this journey. She's so much stronger than me. Every day she keeps going, keeps moving forward. She's brave, kind, compassionate, and intelligent. She amazes me. We will keep praying for an intervention that treats the cause of her condition instead of just attempting to control the symptoms, something that will make a real difference in her quality of life. The current standard of care is insufficient, ineffective, and unsustainable. She deserves better. Everyone with this condition does. Thank you.
Wow, a lot there, right? Listening to all the stories. Thank you all. Very brave, very courageous, and we appreciate everything that you did. Let's give them another round of applause. All right, so we're going to pull out our devices again. We're going to start with a few questions here, polling questions. And our first question, we'll give you a second to pull that up, is which of the following HypoPARA-related health concerns have you or your loved one ever had? Please select all that apply. A, brain fog or cognitive dysfunction. B, paresthesia, numbness, tingling sensation. C, seizures. D, muscle cramps, tetany. E, fatigue. F, kidney stones. G, chronic kidney disease. H, heart arrhythmias. I, laryngospasms. J, calcium-related cataracts. K, dental issues. Or L, other. We'll give it just a minute to come up. Choose all that apply. All right. Looks like we have a lot of fatigue happening. Paresthesia, the numbness and tingling, I think we can relate. Brain fog. Paresthesia is still up there, the fatigue. Seizures, kidney stones. I think a lot of patients can definitely relate to that. Chronic kidney disease, heart arrhythmias, laryngospasms, cataracts, and dental issues, and other. All right. Our next question. Please select the top 3 most troublesome hypopara-related health concerns that you or your loved one has ever had. A, brain fog or cognitive dysfunction. B, paresthesia, numbness and tingling sensation. C, seizures. D, muscle cramps, tetany. E, fatigue. F, kidney stones. G, chronic kidney disease. H, heart arrhythmias. I, laryngospasms. J, calcium-related cataracts. K, dental issues. And L, other. Here are your top 3, picking the top 3. Brain fog, cognitive dysfunction, sitting right there at the top. Muscle cramps and tetany. And fatigue, as we suspected, right? A lot goes into this. We heard a lot of that this morning. All right. So I want to go on and elaborate on this a little bit further. And for patients that have joined us that are not on the panelist or caregivers, we ask you guys to participate as well. We're going to ask a few questions, and we want to hear a little bit more of the detail around your HypoPARA. So the first question is, out of all of the symptoms of HypoPARA, what are the 1 or 2 things that have had the greatest impact on your life, and really how? Who would like to start us off? And we have mic runners. John's going to run, and then we have Liz somewhere here on the other side. Who from the audience would like to share patient? We have Michael. Okay.
Hi, thanks. I'm Michael Zwern. I live here in Washington, D.C., so I just took the metro. I have idiopathic hypoparathyroidism, and in the interest of gender equity, I'm happy to speak on behalf of the minority of men with the disease. My long-term concern is the kidney function. I've been managing hypoparathyroidism for about 14 or 15 years, and initially was the standard of care with calcium and calcitriol, and managing the calcium levels somewhat crudely, but keeping them in the right ranges. And it wasn't really relayed to me until really quite a few years into the treatment, that my kidney function had really been in decline over the span of a number of years, and I was now facing chronic kidney disease. So in addition to the endocrinologist, I now have a nephrologist whom I'm consulting regularly with. So my long-term and daily impacts are really the concern over the kidney function. Mm-hmm. Fortunately, I don't have a lot of the issues with brain fog, and I have a very active professional and family life. But dealing with the potential for kidney damage over the course of multiple decades is really a long-term consideration, and it also really affects my quality of life as I'm addressing the fact that managing the calcium levels are only one part of the overall impact of the disease. So that's my overall take, and I'm fortunate, I suppose, that some of the most severe acute impacts haven't ever been a primary consideration for me, but the long-term chronic impacts are definitely there.
Absolutely. Thank you so much for sharing. Who else would like to share the 1 or 2 things that you feel has affected you the most with HypoPARA? Amelia?
Ever since I've been diagnosed with HypoPARA, that first summer, I was super depressed and had so much anxiety, and it's just almost haunted me since then. It's never fully gone away, and it's always there. sometimes it's more, sometimes it's less, but I've ended up in mental hospitals or crying on bathroom floors, having a panic attack, or not even able to get out of bed because of my body aches that get me depressed. And I've had to go through so many doctors and so many medications just to find a simple solution to this problem. And even now, it's still not the best.
Okay, thank you so much for sharing. And Sherry?
Could you stand up for us?
Thank you. My name is Sherry Gaunt. I'm from New Hampshire. I was diagnosed idiopathic hypopara at age 7, and I am 39 years old. So just to answer the question personally, first, ignore my face. I am badly bruised and battered. And it actually, I can't exactly fully blame HypoPARA, but at the same time, I can. It was a very foggy day as far as brain fog and fatigue, and I had gone out to dinner with my husband and returned home because I was really, really low calcium-wise and knew I needed to get to the bed or to a recliner or somewhere where it wasn't in the middle of a restaurant so I didn't seize or go into full tetany spasms. So we rushed home and got home, and I went to go step up and misstepped the top step, and I went head first, full body weight into the storm door. So I fell, ended up hitting my head clearly very hard and face, and severe concussion. I actually have a brain bleed. I broke one finger, dislocated one finger and 2 toes just from a simple fall. So when you're foggy, it definitely is something that's more than just the fatigue or I'm tired. It's foggy, it's unclear, it's a little brain fog. It affects everything. It's those little steps you take that everyone takes for granted. It's those everyday things. It's hard to pinpoint just, one symptom or one particular thing, but it's overall. And it's difficult, to have some of the sponsors and everybody here that looking on, that isn't a patient or a caregiver and seen everything firsthand as long and as many years as all of us have. And personally, I can relate to all of you guys on so many levels. It becomes something that when we refer to cramping and spasms and the numbness and tingling and that sort of stuff, with the tetany spasms, with me and with a lot of us, the tetany spasms in my hands, they get so tight that my fingers dislocate and they pop out of place. Mm-hmm. They completely swan's neck deformity backwards, and I have to pop them back into place. They have to go back. The longer they're out, if you wait for x-rays and wait for ortho, wait to numb it up, to pop it back into place and get them back situated, it's too swollen to get back in properly, and then it's splinted and casted and all that. So the sooner I can get them iced and, just give me 5 minutes so I can work myself up and talk myself into it and ice it up and pop them back in and we're good to go. Mm-hmm. So you continue on your day. And it's just been one of those things that you have to keep going. And that's the tetany with my hands, but the cramping, muscle spasms and things like that we deal with. Think of your everyday Charlie horse. Every month or so, you might get that, middle of the night cramp in your leg. You can get up and walk it off. And then even that, 2 days later, it still kind of lingers. Like, oh yeah, that was from that cramp I had the other night. I walk it off. We can't just walk that off.
Right.
That's something that we have that, that they think of your worst Charlie horse times 10, but from head to toe, not just your calf. It's your whole body seizing up. And it's something that we take those terms and, kind of throw them around and make it so it's, all muscle spasms and tetany and this and that and numbness, tingling, but it's the way we actually feel. It's not just spasms and just this and just that. It's the pain that goes along with it. And, with all the hospitalizations and IVs and ports and whatnot, with me personally at most, it was IVs every other day for 8 hours a day when treatments weren't an option.
Thank you.
And we need other options. We need to get there. So hopefully there's hope for the future.
Thank you so much for sharing, Sherry. All right, so we've heard about fatigue, we've heard about the kidney, we've heard about the bones, the tetany and everything. I want to go to Michelle. Is there anything online you'd like to share?
Yeah, there's a lot coming in
Okay.
really quickly. We have Louise from Texas saying that Her worst symptoms are the fatigue, but she also worries about the high calcium excretion in her urine and the anxiety that she panics about, is today going to be the day that I can't breathe or something worse is going to happen. And we have Wally from Miami, who again is stressing the emotional stress of just having the disease. Those are the
Very good. All right, thank you. And Caroline?
I'll be speaking later, but one of the things that's really hard about this disease is most of us are women, and women don't tend to get listened to in a medical setting. We tend to be dismissed. And we come into the emergency room, and I avoid the emergency room. I have been known to sit in the parking lot for 6 hours and treat in the parking lot because I don't want to go in. Because I come in and I get told, have a Xanax, it's just anxiety. And I look at them and it's like, of course I'm anxious, because tetany and the paresthesia, it starts in your fingers and your toes and it creeps in. And hour by hour, inch by inch, it moves towards your core as your calcium continues to drop. It feels like a timer, like from a movie with a bomb. Because I know when it gets to my core, I'm going to lose my airway and my heart's going to stop. Of course I'm anxious, but that's not my core symptom. It's a comorbidity, and of course I'm anxious because I've got to count down until my body seizes and stops working. And we get ignored and we get blown off, and so we don't seek treatment. We figure out ways to treat at home. We treat in the parking lot. We just anything to avoid going in and having to be, in this incredibly vulnerable state and in this incredibly painful state while being told that we don't know what we're talking about, we're not experiencing what we're experiencing, and being told that, no, we can't have the treatment that we need and we can't have the calcium that we need.
Absolutely.
So,
thank you so much for sharing. Carolyn? All right, and we'll go in the back here.
Hi, my name is Anna. I live here in the DC area. I had surgical HypoPARA. I have it from the surgery 7 years ago. So my biggest issue, my symptoms are mild. I'm lucky. I'm very sorry to hear about all the stories today. My biggest source of anxiety is the information, due to the information vacuum we have about drug approval. Right? Are we looking at 2 years? Are we looking at 10 years? These drugs have already been shown to be effective and safe from the trials that are ongoing in the Naptera. So I think we really need, for everybody's anxiety, and I think it would help all of us, knowing just a little more, and for the doctors too, about where we really are here, right? Other pharmaceutical companies synthesize molecules all the time. Why are we still waiting? And what is the future look like for all of us?
That's a really great question. And I think there's a lot of online forums that we can talk about that with that. But today, we really want to keep it kind of to symptoms, which, right, we've heard all these people up here talking about. So is there anything that you want to share about your specific symptom that you would love for the FDA and the stakeholders to hear about?
Yeah, I mean, I have the tingling and mostly, I have tingling and it is annoying and it interferes with work.
Yeah.
And the other part that's hard is the family, getting anybody to listen to you when you even just say the word HypoPARA, you've lost them. And they're also confused. They think it's just low thyroid or something low thyroid. Well, I have that too, of course, because I have thyroid. If it was only that, right, if we could just be only hypothyroidism. So I think that's really another issue that needs to be addressed. And I think here the doctors would be really play a key role in helping to educate all of society, and as well as our family members, that this is not just nothing, that it does impact our lives.
Absolutely. Thank you so much. And we're actually going to transition into another question, and it's about family and friends, right? Because we do talk to people, and we try to talk about hypoparathyroidism, and people will say, well, I got a thyroid issue too. So sometimes you might feel a little dismissed around that. But I wanted to ask, what is one thing that you wish others in your family and friends, and especially your doctors, understood about the disease? This is not a polling question. I'm sorry if I got you guys confused. I just had another question for the audience. My fault. Yeah. So I just wanted to hear a little bit more about your family and friends. What is the one thing that you wish, Miranda?
I wish family, friends, providers would know that even when our levels are normal, we may still feel like crap. And one moment in the day, we may be okay, and the next moment we may not. And many times those symptoms may be invisible. So if we're telling you, I'm not okay, it's not helpful when you're like, well, you were okay an hour ago, or you look okay, because you can't see all the symptoms I'm having in that moment.
Absolutely. Thank you so much. Danette? Yeah, we're going to hold, if you can stand, and this is Danette.
Some of the folks on the panel touched on that, which is so many things impact your calcium, whether it's what you eat or how much you sleep or how active you are, and you don't always, you can't always control for all of those things. I know several folks mentioned that, and I think it's the unpredictability that sometimes your low calcium comes out of nowhere. And I know at least my first 2 or 3 endocrinologists didn't understand that too well, and we were always looking for the cause. So that's one thing I would say is the unpredictability of it all.
Very good. Thank you so much, Danette. All right, who else? Sharing with your family and friends around HypoPARA. Any other comments, Julia?
Yeah, piggybacking off of what Miranda said, getting a comment such as, but you look so healthy, but you sound so educated, but you've accomplished so much. It is great to be acknowledged for hard work, but the importance of not dismissing those symptoms, or not dismissing those achievements as indications of a well-managed disease or a simple disease. It just means we work a heck of a lot harder to achieve these goals than maybe someone without HypoPARA. So I think it's important for those coming behind us too. They know that they can achieve their goals. They can shoot for the moon. However, being acknowledged that it's extremely difficult is also really important for clinicians, researchers, and caregivers to understand.
Absolutely. Thank you. Michelle, you have anything else online?
I do have some stuff online, but I do want to add a personal comment.
Sure.
I do wish that when you go to the physician that, and I hear for myself as well, I've heard from other patients that you weren't dismissed, and that when I do have a low that there is no explanation for, and a doctor says to me, well, you must not have been taking your medication. Why is it assumed that I'm non-compliant automatically because you can't explain what's happening to me?
Mm-hmm. Yes. Very good. Thank you.
So that's my personal. Now online, we have people that say their doctors don't understand and say that their symptoms aren't related to their disease, even though everybody on the Facebook group is telling that they have the same symptoms as them. And it's not as simple as getting more dairy in my life. That's one comment. And they wish the ER doctors knew to give IV calcium and when it was appropriate to discharge them, because it's not when I'm still at a 7.
There you go. Thank you. We have Joanne, and then we'll go over here.
My name is Joanne, and my anxiety is already like crazy speaking in front of this group. I want to say that the lack of support from family and friends and the comments don't help whatsoever. I think that, I'm not sure, but it kind of seems like those who have more support, physical and emotional support, do better with this condition. The poor comments that have been made don't help whatsoever. I once had, I share a lot of information about the condition in hopes to gain support. And for example, I've had one person say, it's easier to blame than understand. And I didn't cause this. I had surgery that caused this. So, having that support would be huge.
Thank you. Thank you, Joanne.
Hi, my name is Tisha. I'll be speaking later, but I feel like it would be helpful for our supporters to just, and our caregivers to just understand and educate themselves about the disease itself. So I know we can tell you a wide range of symptoms that we're having, right? But you won't really understand it unless you actually took the time to maybe accompany us to the doctor, maybe do some online research, maybe attend some webinars with us, or to just educate yourself on what's happening, because we're having a wide range of things that's happening all to us at one time, right? And it's not easily explainable. I myself, I'm sure, along with most of you all, get tired of trying to just explain the disease itself, right? And getting all these stupid comments that, that's pretty laughable, but it's a serious thing. So I just think just to take the time out to just become educated yourself as a caregiver and as the support of that person who's battling this disease. So
thank you so much, Tisha. And Bob.
Yeah, my name is Bob Sanders. So there was brain fog right there. You kind of lose your train of thought. It happens.
Who am I?
It happens. No, one of the things I want to talk about, right, is we talked a lot about support. Thankfully, my daughter has a pretty good support group. Her dance team has seen her at her highs and at her lows. And it's to the point where even the dance moms on the other girls, they carry medication with them. So in case I forget to bring calcium or vitamin D, then they have some with them as well, right? But I think as patients, we also forget, and the doctors forget, that they work for us, We're their patient, but if you're not getting the care that you need and they're not listening to you, then you have to walk away. At some point in time, you have to own that. And we've had to do that to a couple of pediatricians, right? My number one rule when I go talk to a doctor or an endocrinologist or a pediatrician, whatever it is A, are you going to be able to listen, and then can we work together? Mm-hmm. If they're willing to work together and work with me, then we could start something. One of the original medical doctors on the medical advisory board, Dr. Barry Bennett, he was a family physician. He wasn't even an endocrinologist. And that guy is extremely knowledgeable, but he worked with my dad. He worked with, I'm sure, with you, Dr. Manstadt and Ruben, and everyone else over the years, and educated himself, right? So don't give up. Again, the doctors work for you. It's not the other way around. Mm-hmm. You're their patient, yes, but if you're not getting the care you need to know when it's time to go find somebody else.
Very good. Thank you, Bob. All right. So now we're going to move on to 2 polling questions. The first polling question, if you want to get your devices out, is what specific activities of daily life that are important to you or your loved one that they are not able to do or struggle with due to HypoPARA? Please pick the top 3. A, regular sleep. B, social interaction. C, walking. D, attending school or having a job. E, household chores. F, other. Don't we wish we had the sleep? Regular sleep is your top right now. Social interaction, which we just heard about with our family, our friends. For some of us having jobs, for some of us going to school. Just sometimes even walking is a little tough, right? As Sherry talked about earlier today. All right. Second question for polling. What worries you most about you or your loved one's condition in the future? Pick the top 3. What worries you the most about you or your loved one's condition in the future? A, seizure activity. B, symptoms will get worse. C, not knowing what's causing pain. D, loss of current skills and functioning. E, social isolation. F, needing extended or long-term care. G, who will care for my child if I'm not able to? H is other. Give that just a few minutes for everybody and our people online. Symptoms getting worse, right? Symptoms getting worse is coming as our top. Loss of current skills and functioning. Needing extended long-term care. Who will care for my child if I'm not able to? Seizure activity. So yeah, it looks like our symptoms getting worse is really what we're super scared of, right? Okay. So I'm going to ask for a little bit more discussion around these. And when you think about how does this affect your family the most, right? We had a couple of them this morning talk about how it affects their family life, and we just want to expand on that a little bit more. Who would like to take a patient or caregiver that would like to share about how do you think this affects your family the most? We have one back there.
Hi everyone. My name is Jane Fry. I'm a parent of 3 young kids. I'm also a HypoPARA patient. My kids are 5, 7, and 1. And I know that for my family and for me, when I get sick, which is a lot with little kids, it always causes some impact on my calcium levels. I have trouble absorbing my medication and often end up having to go to the ER. So for my family, there's just always a struggle in trying to figure out how to arrange quick childcare, how to get to the ER, whether I'm going to drive myself or whether my husband's going to drop me off and stay with the kids in the parking lot until they know that everything is taken care of. So some impact on me and my family.
Thank you, Jane. Thank you for sharing. Michelle, comments online?
They're coming in so fast here. This is actually from a caregiver who says, my mom has been in the hospital for what feels like most of the past 9 years and has to go usually several times a week. She will sometimes be in there for just a night, but most of the time it's over a month. And even though I know she's still with us, she's not, and I live with her, but I miss her much.
Thank you.
She's always in the hospital. So I think that goes to speak to, we as patients may not realize how the people around us are perceiving it, you know?
Absolutely. Very good, John.
Stand up for us. Yeah, we want to see you.
As far as with coming here today, I actually spoke with my husband as being my caregiver, and he couldn't be here, but I was curious to be able to pass along any information from him directly. And I asked him a very similar question, and how does it affect you? I mean, I see you from a patient perspective, but personally, honey, what is it that, you know, we're gonna need to know that. They wanna know this, that we wanna be able to pass this on. And 2 things he stated was something as simple as just, I mean, our everyday things that we do. You know, my husband has to kind of pick up the slack when we can't do that. If I'm home and everyday chores, everyday things like that, he works his regular 9 to 5 plus doubles, sometimes triple shifts at the state prison is where he works. And so I can not see him for sometimes a day and a half, 2 days before coming home, because I can't work a 9 to 5. I've lost those jobs because of unplanned, unexcused absences. And yes, unexcused. It's been said that those were unexcused when I've been in the hospital and sick. And then the other thing was, we just had an example the other night. My husband had purchased tickets for a comedy show for us to go to in Boston. And we were super excited to go to that show. And before doing so, I was doing the research, and he was asking me, why are you looking stuff up? What are you looking for? And I'm looking for things like how close the parking is. How far am I gonna have to walk? Is it something that, can you drop me off? Can you this, can you that? Because he currently has a back injury himself. So he's like, honey, I can't drop you off. Are you gonna have to drop me off? So it's one of those things you drop off at the door. How far is the parking lot? How far is these are just things you don't have to think about, but he was thinking in terms of thinking ahead for upcoming plans, how he has to make adjustments for me. Absolutely. And he's always thinking about that next thing, like rather than committing right away to it, I need to make sure Sherry can go. I need to make sure that it's gonna be able so my wife can join us type thing. Otherwise, his plans will have to change too.
Very good. Thank you so much again. All right, with Jocelyn.
Okay, so I'm a patient of genetic HypoPARA, and basically my whole life, not only have I had to, I've been taught to keep an eye on my calcium level. My parents have always worried about me about that. So not only am I on top of it, they're mostly on top of me. But I have to keep really a good eye on it because I do dance like competitive, so I work out, and it's extremely overwhelming. And once in a while I do get brain fog during dance, so it's like kind of overwhelming there, and I don't know how to explain it.
Oh, thank you so much. It's really scary when you're in the middle of a routine and all of a sudden your brain fog happens, and then you're like, where am I? What do I need to do? So thank you for sharing that. We really appreciate it. Okay, we have back here.
Hi, my name is Jacqueline, and I'll be speaking later on the panel. I so graciously gave my daughter HypoPARA too, genetically, so we have a bond. But she saw me when I was really, really bad as a kid because I was basically in bed for 15 years, undiagnosed. And so for my child to witness me, and now she is exhibiting symptoms, it's really scary as parents to say, you're gonna be okay. You know, there's gonna be a cure out there by the time you reach my age, which I'm old, but by the time you reach my age, there'll be a cure. But, you know, she's mentioned like, am I gonna be like that? She's also an extremely gifted athlete, and I send her on an airplane with her team all over the country, and the parents know she has this, and it's just give her yogurt because that's all there is to do. But your friends know, and they look out for her, but as a parent, letting your kid go with a disease like this, and let them fly, which we're a very open family, and you still have to live your life, you still have to move forward, but it's really, really scary. You know, so as I'm texting the parents, did she drink her water? Like, her extra calcium is here. They call her Gertie because she eats so much yogurt, but that's where the stress of our family is now. It's not so much me, it's the child, so.
Very good. And Jackie, you had shared with me yesterday about like your fear of the future of trying to help. You know, what's it going to be like when you may get a little worse? Is there anything you'd like to share a little bit more about that?
Yes, so if I crash and she's crashing, who's caring for her? You know, she's almost 17, and she cannot, you could care for me. She can make her own decisions. She's well-educated, but you still need a parent. And so that's a fear of mine. If I'm down and she goes down, what do we do? Because it could very easily happen. We both crash on the same day.
Yeah, very good. Thank you so much. Anybody else in the audience? And I'm going to go to comments here, and then I'm going to go back there with John. So go ahead.
This is actually a comment on
Go.
a personal note from me. Sort of positive, though, the way it affected my family. But I never realized it. So I was diagnosed before my children were born, before I was married. And my children witnessed a lot of times when I couldn't walk, couldn't do things. And it wasn't until my oldest daughter applied for college and wrote her college entrance essay that my eyes were open to what they saw. And she showed us her entrance essay after she got accepted. And she chose to go into nuclear pharmacy. And her entrance essay for pharmacy school said, I chose this profession because I had to help my mom walk when I was 4 or 5 years old. And I sometimes knew that my mom couldn't come to my events because of her disease, and I want to make a difference in other people's lives, so I'm going to be a pharmacist so that I can make that difference.
Thank you, Michelle. Okay.
Hi. One quick comment. I think there's also the financial aspect. I think for families, at least for my family, it's hard for them because they are aware that at some point maybe they will need to come up with, all the salary in the household if I should get worse or a drug isn't approved quickly enough. So I think that's kind of, it's in their minds. And also they worry, I think, about the same things we worry about once they understand it, which is that our lives will be cut short or really severely degraded. So I'm glad you asked this question.
Thank you.
Think
Thank
about
you.
our family members too.
Absolutely, absolutely. All right, so I have another discussion question for us, for those in the room and online. Do you feel HypoPARA prevents you from doing activities such as, working, shopping? And with these activities, do you avoid them because of fear of a crash? Who would like to share a little bit around that piece of it? Caregiver?
Hi, I'm John. My wife's on the panel up front. We worry about being able to do regular activities with our children on a day-to-day basis. When we try to plan trips and do things to make our kids have a normal life, I'm constantly worried about if Miranda's gonna crash and how quickly can we get her either home or to where she can get proper treatment. When we get to there, are they gonna listen so that she can get proper treatment? Who's gonna take care of our kids if I have to take them somewhere? So this all goes into everything, even just visiting a lake that's like 30 minutes from our house. All that thinking has to take place.
Mm-hmm. Thank you so much for that. Andrea?
Yeah, I think for me it's been really hard to go from very active and very strong and then watch my body deteriorate. I had to go from a slalom ski to what I call my old lady slalom ski. That was a wide body. Last summer I had to go to 2 skis. I went and I'm losing strength in my hands, and so I've had to learn to do farmer carries and different things to try to help it. I had all my kids at the lake and their friends, and I couldn't even get the gas cap off the boat. And so for me, kind of just the overall general slow slide into impact has been painful. I changed my own oil, and now I have to use a breaker bar to be able to get the plug out. It's just craziness. But I've learned that I have to use assist tools. Like there's a tool I can use to get the gas cap off. I use a cart to get the gas cans down to the dock. And it's defeating. You feel like less of a human being as you just watch these little pieces slip away. But I still go at it. I still exercise. I lift weights. I try to make sure that I minimize what I lose, but every year I watch a little bit of my body stop functioning the way that it should. and it's irritating, and it's hard for my kids to watch.
Mm-hmm. Very good. Thank you, Andrea. Michelle, online?
There's a lot of talk about people not being able to do social interactions, not having friends because you can't expect friends to understand why you may have to leave in the middle of an event. Making one of the most frustrating parts is tracking what you're doing so that if you do have something planned that you don't have to interrupt it. Yeah, it's kind of a lot about social interactions and not being able to participate, avoiding going to even scheduled family functions because it's easier not to go than it is to explain what's happening to you.
Very good. Thank you. All right, and we have Liz in the back.
Hi, I'm Liz Zarumsky. I'm post-surgical 10 years. I will say traveling is really hard for me. I just went to California with my daughter for club soccer for a showcase, and it usually takes me about a week to get back to normal, and a lot of people don't understand that. Even my husband that has known about everything, and I think sometimes he still doesn't understand like the little things, and my mind, my body, like my arms hurt, my hands hurt, my legs hurt, everything hurts, my brain hurts. And it's to the point sometimes where I'm crying because I just want to get back to normal, but I have to lay in bed for a week for me to get back to normal. Even if I try to take all of my pills and all of my supplements, I'm still not the same. And for some reason, I will say also, I never used to have anxiety before after surgery. Like even just standing up here, anxiety, crazy anxiety.
Mm-hmm.
Sometimes I won't even put up my hand because I don't want to talk in front of people. And I used to be fine with it, but it's just everything's different now.
Absolutely. Thank you so much, Liz. I think Andrea related to this morning when she talked about like the quivers and how it just makes you feel, just more scared. And I think with hypo, that's exactly what you were talking about as well. Thank you. Katie.
Thank you, Patty. I'll also be speaking a little bit later today, but this kind of crosses over the previous question that Patty asked and also the most recent one. But in terms of things that I would avoid or didn't really think I would have or be able to have in my life, I would say, kind of to piggyback off what Michelle was saying, the social interaction and relationships. I kind of had the impression that having a chronic illness and a rare condition that was hard to treat would make me very difficult to be with, that it would make me harder to love, and that I also wasn't sure if it would allow me the ability to have children, or that having children would be a much more difficult process, and I already expect that it will be a more difficult process because of this condition. And so that was a big realization for me, and I kind of started to plan my life around those possibilities in a way that was very disconcerting and sad. And so we definitely need better options for us all so that we don't have to think like that.
Absolutely. Thank you, Katie. All right, we're going to go back online here, and then we'll go over to Joanne. Go ahead.
We have a couple coming in online. This one's actually coming from South Africa, so welcome. Unable to work full-time in their management consulting work anymore and afraid to meet with clients because they're afraid that they won't be able to think clear enough to discern complex problems. And then we have one coming in from Utah that says they don't participate in exercise anymore, go to the gym, walk, and are afraid to do activities with their kids.
Absolutely. How many of you tend to write things down as people are talking? A lot more than you used to, right? Absolutely. Very good. All right, Joanne?
Besides not having the ability to work, I was a website developer, and I seem to have lost my creativity when I acquired HypoPARA. But I enjoy hiking and snowmobiling with my family. I will not avoid going unless I'm having symptoms or I feel like if I go, I'm going to crash. And the biggest thing I wanted to mention is I don't have a fear of crashing, because if I feel well enough to do something, I'm going to do it just to get the joy of being able to be active when I can. And I don't think about the aftermath. I just live in the moment and, you know, get out on the trails. And I love it so much that I can't put that behind me. I'll do it when I can. When my family goes without me, I just try not to watch them leave, because it's kind of sad, but I feel it's important to do what we can when able to. I don't want to, you keep moving, what's that saying? A body emotion stays in motion, so I do my best to do that.
All right, thank you, Joanne. Okay, we have back here, and then we'll go over here to Miranda.
Hello, I'm Farrell, Tisha's husband of 3 years. I knew her when she was in her young 30s, and before she was diagnosed, and she was overactive. She did everything. Danced, mimed in church, sung on the choir. Anything that you would ask her to do, she would do. Now, she doesn't have the energy to do it. And it's more so on the lines of, I don't want them to know I don't have the energy. So she stays at home. She stays close to home. We go maybe 4 different places, her parents' house, my parents' house, maybe around the corner to her sister's house. She's always inviting people to her house, but she don't go too far. And day by day, we've been married 3 years, so in the last 3 years, her job has got more difficult. And she didn't want to let me know that she's having fall. She have muscle spasms at work, and she has to go off to herself. She works in the medical field, and to take care of someone when you need to be taken care of is a hard thing. But what I have a problem, I could see us having a problem with is a person that wants to take care of someone needing to be taken care of, and letting me help her and take care of her when she's such a big person with such a big personality to do things for others. Even when we have birthdays and stuff, everybody else, it's a big thing. With her, no, I don't want to do nothing. I don't want to go nowhere. So it's the tiredness, the fatigue, the muscle spasms that I only see at night. She doesn't let anyone outside of the bedroom see how hard she's hurting and how many muscle spasms she's having. I believe her son doesn't even know the severe of her disease. And to get help, to see that she could have a quality of life, to see her grandchildren and be active in her grandchildren's lives would be great, wonderful. I think she doesn't say it, but that's her fear. She wants the quality of life. She wants to grow old with me, old and gray. She's always telling me to take care of myself, but I think she's reverting back to me taking care of myself, meaning I want to take care of myself while I can be here with you, while I can grow old, while all this stuff can assist, and I can be a grandparent to my grandchildren. So that's what we have fear with.
Thank you so much, Farrell. That was wonderful. And it really spoke to that social isolation that we talked about earlier today as one of the top categories. So thank you so much. All right, and Miranda?
Yeah, I was just going to add, I'm a mom to a 2 and 4-year-old, and I feel like you have to be almost creative with how you live your life. We have a big staircase in our house, and there's times when I struggle to get up it, and I've had to teach my kids when I can't carry them from a very young age that they have to go up the stairs. They have to climb in their car seat. My 4-year-old has to help buckle my 2-year-old in his seat when I can't buckle him. You try so hard not to let these things limit your ability to live your life, but it's challenging, especially with children. You teach them things that you would never think you would have to teach them, especially at such a young age. And so I just wanted to add to that.
Thank you, Miranda. And Julia?
Yeah, and just the same thing. You teach them things that you wouldn't teach other kids. I hope my children and my husband know that they have a safe place to express their frustrations with this disorder. Because seeing mama in the hospital is not fun. If mama has to miss a soccer game, and it sounds really shallow, but it's important for a child. And so allowing them a safe place to express their frustration and not take it on personally has been difficult for me, but I think it's really important for our children. But that's an aspect of the management of this disease that's that changes as you enter into adulthood and motherhood.
Thank you, Julia. And Michelle, sorry, go ahead. Sherry?
I just kind of wanted to touch real quick. Same thing, talking about children with the day-to-day stuff and things you guys do with your kids in order to lead a more normal, quote-unquote, life because of, stability and not sure. But, with myself and my husband, it came down to even family planning altogether, long-term, in having children. It's something growing up, I always wanted to be a mom. I knew that's, in kindergarten when they ask you what you want to be when you grow up, and everyone, I want to be a firefighter, I want to be a police officer. I raise my hand and say, I want to be a mommy. It was something I always wanted to be a mom, and as I got older, I realized, there were going to be complications with that, but I was bound and determined and, went that route with my husband, and after experiencing multiple forms of loss throughout the years, realizing that wasn't in the cards for us and we needed to go a different route. And if I was still determined, so we look into adoption and foster care. And super excited, we started doing that, taking the courses to become foster parents. It's like, we can still do this, I can still be a mom even if I don't carry that child myself and it's too dangerous and we've had too much loss and foster care, where we can do that, or adoption. And we ended up, after taking all the courses, we end up getting the interviewer to come out, and after the meetings and such, and she looks at her paper and it says, and what is it that you do for a living, Sherry? And I was explaining that I have to kind of work from home and sort of do my own hours, but I'm home, and this and that. And she's like, but you said you're on disability. I said, yep, I am. I said, I've lost multiple 9-to-5 jobs because of the lack of reliability and stability and not sure how I'm gonna feel in a given day, but I keep going. I get up anyway, I gotta do what I do. She said, well, I'm sorry, unfortunately, with you being on disability, foster care adoption's probably not in the cards for you. And it's just a gut punch to know that it's one thing, you can't have your own children, but now I can't even adopt. You think, because someone is looking in from the outside thinking that, I can't care for a child only because I'm on disability. It doesn't affect my lack of ability to be a mom. I mean, they weren't even giving me a shot. It was like a big red X, like, nope, never mind, all right, I'll leave. And you just felt so dismissed. I mean, we feel dismissed so many times in our day-to-day, but more of a long-term planning. It was something that has affected us, in the big picture, and even having children, so.
Thank you so much. Such a personal story. We appreciate you sharing that this morning. Thank you. All right, and Michelle, I'm going to go to you with comments online.
I have one from Kai, and she says, on my best days, I can walk through the aisles of a grocery store and put groceries away, But on the worst, I can barely get dressed and have to focus just to breathe.
Okay, anything else?
No, not right now, thank you.
Okay, Bob?
Yeah. Again, I grew up in a family of HypoPARA patients. It's very odd. It's been a surreal kind of experience for me. And I remember one day my dad came home from work and he was saying that he had to turn down a position of work. It was a management position where he was at. And he was a radiation technician, right? You get in these high-stake positions and you cannot afford to make a mistake. And you have to think on your feet, you have to think on your toes. And you know, and he explained to me that that's not the first time that they've offered him positions. And ultimately, he ended up retiring early because of this, right? He just did not feel like he could be in a position to make those quick second thoughts because of his brain fog at any given time. And he had to study twice as hard as everybody else to make sure he stayed up on his certifications. And eventually, it ended up pushing him out, right? And that's one of my fears as well. And I think in our family, maybe it's a TBX1 thing, but the brain fog is very real. It is very heavy in our family, and it does make me worry because, again, I work in a very high-stake position. I work in the oil field. We're doing jobs with 15,000 pounds of pressure on the line where 1 second can mean the life or death of somebody outside. And, you know, so you're constantly weighing those things. And like Sherry said, I got 2 younger brothers that are on disability. They cannot work, physically cannot work. They can't hold a job down. One lives with my parents, is kind of a caretaker, and the other one actually ended up homeless on the streets of San Francisco for a time being until we figured out what was going on, because we just lost contact with them. And it's real, right? And just being, it's so different seeing everyone's challenges and what they're going through, but it's real.
Absolutely. Thank you, Bob. All right. So this morning we talked a lot about the symptoms, the effects on our daily lives, and the burdens that we carry around with being a HypoPARA patient. This afternoon we're going to talk about current and future therapies. So for now, we're going to take an hour-long lunch break, and we'll come back at 1:05 Eastern Standard Time. But before we leave, on your table, and for those of you online, there's a digital copy of a survey that we just did as a HypoPARAthyroidism Association. We surveyed 300-some patients. We got 227, I think, responses out of it. And it talks about all the symptoms and the burdens of HypoPARAthyroidism. So that's for you to take away today, and for everybody online, there's a digital copy for that as well. It is literally fresh, hot off the press from yesterday, so we're excited to share that piece with you as well. So everybody have a really great lunch. We will see you back at 1:05 Eastern Standard Time. Thank you. All right, welcome back, everybody. We hope you enjoyed your break and got a little refresher. An hour goes by pretty fast in these things. So I want to just go back and recap kind of the ground rules of this afternoon. Remember, only patients and caregivers are the ones that are allowed to speak during the meeting. We appreciate everybody being here, but we're going to keep it to the patients and the caregivers. We're going to have a respect for each other's emotions as we go through this. As we saw this morning, it can be quite emotional. And the last rule, of course, is I get to ask all the questions. And to set up this afternoon, we're going to kind of do the same thing. We're going to be able to have a doctor come up and speak a little bit to talk about current and future treatments. Then we're going to go into our panelists, or we'll do some polling. Then we'll go into our panelists. Then we will do some polling, and we'll go into an open discussion again. So we're very excited and honored to actually bring up Dr. Michael Manstad. He has been so pivotal in helping the HypoPARA community. So Dr. Manstad.
Patty and Michelle, thank you so much for inviting me here. Thanks, everyone. This has been a very moving and deeply humbling morning, and I'm very grateful to be here. So I was asked to speak about current treatments. I didn't hear the future treatments, but that's okay. So I am an endocrinologist in Boston. These are my disclosures. And so in the middle of, or the center of the discussion is really PTH, parathyroid hormone. And when we talk about treatments, we need to know what PTH does, because that's the one that's missing, and we want to replace its functions. And so you see in the middle in red the PTH, parathyroid hormone, which increases, and you see on the bottom, calcium in the blood. That's well known to everyone. But I want to pause here and really emphasize what the parathyroid glands are doing. Namely, there is this nice negative feedback that we like so much in endocrinology, that in calcium that is elevated will put a brake on the parathyroids through the calcium sensing receptor, and then less PTH is produced, and therefore less calcium in the blood. Calcium goes down, and if it is a little too low, then the brake actually gets released, and there's more PTH produced, and that leads to the calcium level to be regulated really in a very narrow range. And this happens while we have lunch, or if we sit in a conference and don't eat anything, or we're going out and exercise. Unbeknownst to us, there's a minute-to-minute regulation. And now compare that to what we are currently doing with our treatments, right? Which is almost a sledgehammer approach. And then let's dissect a little more what PTH is doing. And so number one, it increases bone turnover and the release of calcium and phosphate into the blood. It tells the kidneys to reclaim the calcium so that there's less calcium in the urine, but really there's then more in the blood. It leads to an excretion, to getting rid of the phosphate that is so abundant in our diets. And through the increase in the production in the kidneys of calcitriol, the active vitamin D, it increases indirectly the absorption of calcium. And no PTH, of course, we have hypoparathyroidism with low calcium, high phosphate, and low bone turnover. And the conventional treatment with calcium and vitamin D, all it does is, it's number 4. It increases the absorption of calcium. That's all that it's doing. Nothing number 1, 2, or 3. And I'm glad people talked about the number of tablets. This is just an example of a very average hypopara patient taking 2 calcium citrate tablets 3 times a day, and calcitriol 0.25 twice a day. That's a very, medium level of medication. These are already 8 tablets. And 8 tablets and plus, all the rest that might be needed every day. That's kind of not an easy way to treat a disease. The other medication that is FDA approved is PTH 1-84 or NetPara, once daily subcutaneous injection. And as we know, unfortunately, the production will cease by the end of this year. So what are the consequences of the calcium and calcitriol therapy, these long-term complications? I just mentioned a few of them, and we have already discussed some of them. Renal complications, cataracts, brain calcifications, depression, cardiovascular disease, infections, and skeletal complications. So it's really not a benign disease. And what I like to do is just take an example of all of these complications and talk a little more about this, and these are the renal complications. So on the left, you see what is normally happening if you have normal parathyroid glands with PTH producing. And you see that in the lower part of the left panel, the serum calcium is increased by reabsorption, reclaiming the calcium from the urine. And on the right side, you see this is not working if there's no PTH and there's loss of calcium in the urine. And all that we are doing with giving oral calcium and calcitriol, we are increasing serum calcium, but at the same time increasing urinary calcium excretion, right? There's a strong correlation between the two. And so the loss of calcium in the urine is not something you can feel, but there might be long-term consequences. And so there was this study done in Boston, more than 10 years ago, where we examined the charts of 120 patients with chronic hypoparathyroidism. And on the left side, we identified about half of the cohort having some imaging done. And when we looked, or radiologists looked at the images, almost a third of those who had imaging done had kidney stones or nephrocalcinosis. And you see these two red arrows. They point to these white spots. These are kidney stones of one of the patients in the trial. Around these kidney stones, that's the normal kidney, and in the middle, this white thing is it's the spine. And so does that impair or have anything to do with kidney function? On the right side, you see a diagram that shows you the proportion of patients with chronic kidney disease, CKD. And the black bars is the normal, or taken from the normal US population. You see a well-known age-dependent increase in chronic kidney disease. You see the different brackets of ages. And then when you superimpose our patients with hypoparathyroidism in the gray bars, you see that there is a several-fold increase in the prevalence of chronic kidney disease in patients with hypoparathyroidism. So really that told us, Houston, we've had a problem. And this study was followed by many other studies. This is from a review that shows you the percent of patients with chronic kidney disease. And on the left, you see the N numbers. These are the numbers of patients within each of these studies. You see it ranges from 33 to really large studies. The last one is from the nationwide Danish study with 688 patients. And from that study is this diagram on the right side that shows you compared to patients without hypoparathyroidism, there's about a 4-fold increase in kidney complications, including kidney stones and renal insufficiency. And so to decrease the urinary calcium, what we are currently doing is to lower the serum calcium, because on the right side, the normal serum calcium levels like 9.2, 9.5 are too high for hypopara patients, only because of the urinary calcium. Because then the urinary calcium is too high and there's a higher risk for developing kidney disease. So we are targeting low to low normal serum calcium levels, but then on the left side, they make you more prone to having symptoms. So that is the conundrum that we have heard today about, and that is something that the physicians have to deal together with the patients, and there's sometimes a good middle, but often there's not. And so this is my last slide, I tried to summarize or list some of the actions of PTH, and Certainly, I don't claim that these are all. And what calcium and calcitriol, the SOC standard of care, does, and the currently available PTH on the right side. So what we can do is increasing serum calcium. That's what we can do very well, but that's pretty much everything, right? So in the excess means it's not being fulfilled. So you see, everything else, standard of care really does not address. So normalizes urinary calcium. We just talked about this, right? It cannot do this. PTH 1 to 84, there are conflicting results. Different studies showed no effect. Other studies showed some. Keeping the serum calcium stable. We cannot do this with current treatments. There is the problem that how often do you measure calcium? Often it's once every so many months. Well, it tells you something about that moment. It doesn't tell you what was it in the morning, what was it later during the day, right? So I personally believe the fluctuations in serum calcium is a big lack of, we need to pay more attention to that, I think. Adapting to challenges, meaning what if a woman has periods and the serum calcium goes down? What if you're going for a run, right? These medications, you're taking the same medication. Only you can take extra ones. But really, in the best case scenario is someone else, like a parathyroid gland substitute would do that. Normalizing serum phosphate, actually, PTH does it very well. Current treatment doesn't do it. Normalizing magnesium, very similar. Bone turnover, so PTH products increase the bone turnover, and the goal is to increase it to a normal level. The ease of administration, that's a little bit in the eye of the beholder. Clearly, the current treatment, I don't think it's very easy to administer, even if it's just a tablet. PTH currently has to be administered as an injection. There are many people who say, well, this is not really what I want to do. Other people tell me it's actually much easier than taking all these tablets. Improving quality of life is a big issue. And protection against complications, so long-term complications. That's hard to know and hard to study because you will need a lot of patients over many years to really study that. So the summary is we need better treatments to address and replace the different functions of parathyroid hormone. I thank you very much for your attention.
All right, thank you so much, Dr. Manstedt. Really appreciate all the work that you and Dr. Rubin do with the HypoPARA community. Truly, let's give it up for them again. All right, so we have a new panel up front here. We are happy to have you listen to all of them, and they're talking. They're going to try to get a little bit more specific on like current and future therapies, but they'll also be sharing their story with you. So our first presenter is Caroline. She is a post-surgical patient. So Caroline.
Hi, my name is Caroline Wormkessel, and I've worked in quality and regulatory in an FDA-regulated industry for my entire career. This makes me slightly different as a patient. I met my husband training for the 500-mile California AIDS ride. We both have our pilot's licenses and our scuba certifications. I used to dive several times a month, fly weekly, go on 30-mile bike rides on a whim, and I never needed to write anything down. Like 75% of HypoPARA patients, life as I knew it ended with my thyroidectomy in December 2012. HypoPARAthyroidism is often viewed to be a low calcium disease. The inability of patients to stabilize on oral medications is a stark reminder that this is an endocrine disorder most similar to diabetes type 1 in terms of severity, blood level volatility, and complexity of treatment. Just from today, the variability in the expression and treatment of this disorder is clear. None of us are using the same medication combinations, and we don't have the same level of stability nor quality of life. HypoPARA is the only endocrine disorder that does not have an FDA-approved hormone replacement option available, and our health reflects this. I started on standard of care. We moved through increasing doses of calcium carbonate and calcitriol, with me being unable to reduce my symptoms. 6 months in, I found my urine levels were over 1,000. I moved to citrates. We made the difficult decision to keep my serum levels as low as I could tolerate to try and save my kidneys while we waited to see if HypoPARA would get approved. I couldn't tolerate blood levels much under 8, but that still left me with urine levels around 450 and no quality of life. I had alarms going off every 2 hours from 6 a.m. to 9 p.m. to ensure I didn't miss doses. I experienced debilitating fatigue, sleeping 36 hours in a weekend, and an inability to go for a walk. Elevated urine levels, heart arrhythmia, tooth decalcification, permanent tetany in my feet. I couldn't follow the narrative in new books. Anxiety, depression, emotional dysregulation. My family has a dark sense of humor, and we call a low calcium event twitch and bitch for a reason. I got into the HypoPARA phase 4 trial investigating twice daily use. In the first hour of injection, my calcium went up from 7.8 to 8.7 with no orals on board. My urine concentration dropped by 75%, and my heart arrhythmia disappeared. The brain fog lifted, the tetany in my feet dissipated. I tried to figure out how to take the other 13 doses home with me, but I couldn't fit my hand in the sharps container. I started HypoPARA, moved up to the 100 microgram dose quickly, and was able to stop orals altogether 6 months in. 6 months in, I made the decision to start split dosing to great success. As long as I kept my activity levels consistent and low, I was avoiding calcium crashes. High activity days still needed calcium. My urine levels were under 240. My teeth were starting to recalcify. September 5th, 2019, my life was shattered again with the FDA's recall of HypoPARA. As patients, we found out when we couldn't get our prescriptions filled. My endo found out when I emailed her. The recall was the equivalent of removing all forms of insulin from the market via a note in the news section of one manufacturer's website. The flood of patients being hospitalized after the recall and the subsequent initiation of the special use program just 19 days later demonstrates the significant and severe patient harm that is experienced when patients don't have access to PTH. Our community continues to experience a traumatic level of harm as a result of losing access to on-label PTH replacement. In one of the HypoPARA support groups I'm part of, from September to mid-December 2019, more than 70% of us ended up in the emergency room with critically low calcium. About 60% of these ER visits resulted in admissions, and at least 20 people were moved to the ICU. More than half of us were in the ER more than once in those 3 months. Personally, 3 of my friends died as a result of this recall. Shortly after the recall, we moved into COVID lockdowns, knowing that we were going to have to use emergency rooms due to losing access to life-sustaining medication, but also knowing if we go to the hospital, we'll get COVID. And if we get COVID and it gets bad enough for us to be hospitalized, we're probably not going to make it. How do I explain all this to my 9-year-old child? My endo moved me to Forteo, but with a 90-minute half-life, Forteo just wasn't the same. My urine levels were high, so we added hydrochlorothiazide, then potassium, magnesium. I woke up daily between 2 and 3 a.m. in severe pain due to calcium crashes. I added in calcitriol, calcium patches. I could now get to 4 a.m. before I woke up with the pain. I was basically bedbound for the week of my period and another week to recover. My teeth started decalcifying again, and since 2019, I've had 6 crowns and twice that number of fillings. I started having kidney stones form for the first time. My vision deteriorated dramatically. COVID lockdown and working from home, ironically, is the only reason I kept my job. In August of 2022, I asked my endo about putting Forteo in the Omnipod. This has been a miracle for me. I have found that I function best with calcium levels between 9.2 and 9.6. My urine levels are back under 250. I haven't grown any new kidney stones. I spent a year in physical therapy, and now I can work out again. I might be able to get my FAA medical back. For the first time, I have hope. When my calcium crashed down to 6.4, I was able to pull myself back to 7.8 in 12 hours using pump adjustments, standing stat orders, and oral calcium. No ER. And I was able to be back in the 9s in less than 30 hours. Before, this would have been an ER visit and a hospital admission. I wish I could have tested at home. It would have saved me a lot, but the standing stat orders worked. Although there are trials for molecules that might be a better fit, I can't consider joining the trials. I would be hospitalized long before the required 30 to 90 days without PTH was completed. I also can't risk being placed in a placebo arm. I would lose my job if that happened, possibly my life. I don't stabilize anymore on orals. When I search through the FDA's clinical trial site, I'm unable to find a single insulin trial that requires diabetics to stop using insulin for any period of time. And I can't find one that uses a placebo arm with no insulin provided to them. It's concerning that I find experimenting with off-label solutions to be substantially safer than participating in an approved clinical trial.
Thank you so much for sharing that, Caroline. Next, we have Tisha, and she is an idiopathic patient. Tisha?
Hi, good afternoon. My name is Tisha Horton, and I'm sorry, Barkley. Just got married 3 years ago. I am a 44-year-old woman living with idiopathic hypoparathyroidism disease. I was diagnosed in 2015 after abruptly losing my eyesight one evening driving off of a freeway ramp. After days of not being able to see, I instantly feared something wasn't quite right. As my vision started to slowly return, I started to notice other symptoms. I became fatigued, so much so that the smallest task started to feel as though I was pulling an 18-wheel semi-truck. My hair started to fall out. Shortly after, my teeth will start to crumble as I ate something as simple as a muffin. My appearance started to fade before my eyes. I knew then that I was in danger. I received a call one afternoon from my doctor to get to the emergency room after finding out my calcium was only at a 4. When I arrived to the doctors, I was surrounded with doctors at my bedside asking if I had cancer to run in my family or even sickle cell to run in my family. I was terrified of what they might have found out, so I braced myself for the worst. They explained to me about the disease and its long-term impact, but I never would have even imagined the worst was yet to come. I spent several days in the hospital receiving calcium through an IV, but it wasn't over yet. I crashed only 3 weeks later. This time, my levels was even worse than the first time before. I couldn't imagine things getting any worse, but I was wrong. I was very wrong. I was still very new to this disease, very uneducated. The hospital stays continued, crash after crash, seizure after seizure, hair loss so severe I became unnoticeable to myself, bones so brittle and weak, spasms so painful that even walking seemed impossible. One day, while in a hospital, after yet another crash, I received 7 calcium infusions. I went into tachycardia of the heart while on FaceTime with my husband. I knew for sure I wasn't going to make it home to him, but the grace of God was on my side. I made it through. I now have a heart defibrillator, and now I'm up to between 60 and 70 pills per day. The whole time while being hospitalized at least once a month. Treatment alone makes me sick. But our fight is not over. It's not over until the quality of our lives has been restored. It's not over until we find new treatment options to slow down the progression of this disease. It's not over until our fear finally becomes our triumph. It is not over until my husband and my family can sleep sound without the fear of a calcium crash happening in the wee hours of the morning. But I'm hopeful. I'm hopeful. I'm hopeful, first, in the God that I serve. I'm hopeful that one day we can find a cure and provide more treatment options. Until then, I stand and I raise my voice and I give a face to this debilitating disease. I am the face of hypoparathyroidism.
Thank you so much, Tisha. Said with so much passion. We appreciate that. All right, next up we have Bob is going to share his journey as a genetic patient.
All right, that's going to be hard to follow. Anyways, my name is Bob Sanders. I'm president of the HypoPARAthyroidism Association. I have a TBX1 genetic form of hypoparathyroidism. I'm the middle of 5 boys, all of whom have been diagnosed with HypoPARA at various stages of development. We all differ in symptoms and severities. I was the last one to be diagnosed in our family with hypoparathyroidism at the age of 18. I grew up with HypoPARA. We were never alone because we always had each other. It's kind of insulated in that aspect. We knew each other's symptoms and signs of low calcium. We had to, so we could stay ahead of potential crashes. We had to look out for each other. But I cannot stress again how different each one of us was. My father, James Sanders, was diagnosed with HypoPARA at the age of 20, or around there. He grew up with doctors telling his parents that his symptoms were not real. They were in his head. He was crazy. His constant fatigue and tetany prevented him from playing outside with his siblings and friends. And he spent his childhood in the house reading books and watching TV. In the early 90s, my father enrolled our entire family into 1 through 34 PTH trial at the NIH with Dr. Karen Weiner. We stayed at the Children's Inn and got to know many other children and families, not only with HypoPARA, but other rare diseases from around the world. During our time at the Children's Inn, my father was inspired by God to create this community connecting people diagnosed with HypoPARA in 1994. And in 1995, the organization was officially recognized by the IRS as a nonprofit organization. Me, I'm one of the lucky ones. My calcium is easily managed. My worst symptoms include brain fog and tingling and a little bit of fatigue. Unfortunately, I have no way to judge how well I am. I could be bad, I have no idea, but because I'm genetic. I don't have a normal. I don't have a baseline for a normal, but this is my normal. But because I grew up with HypoPARA, I didn't understand the vision of my father. It's not because I didn't care, it's because I was complacent. I just didn't know. I married the love of my wife a week before my 21st birthday. Together we have 3 children, 2 girls, 1 boy. All 3 carry the genetic mark for TBX1. I was confident that even if my kids were eventually diagnosed with HypoPARA, I could handle it. I have the experience and knowledge of how to treat the disease, stemming from a lifetime of advocacy. But all that changed with our youngest daughter, Jocelyn. When she was 12 years old, she had her first major calcium crash. I noticed the tetany setting in, and I knew we had to act fast. If she could hold fluids down, then she could take calcium, and we would have a fighting chance. Unfortunately, after an hour, we ended up in the ER in Williston, North Dakota, a very small town in northwest North Dakota. Immediately, I told the doctors about her family history and asked them to check her calcium levels. As suspected, her serum calcium levels came back extremely low. Her symptoms continued to worsen, and she was now experiencing severe tetany, fatigue, and brain fog. She didn't know where she was or what was happening. I told the doctors that if they started her on IV calcium, the symptoms would subside. They did not listen to me, no matter how much knowledge and experience I had. They disregarded the low calcium and instead focused on treating the multitude of symptoms that were related to low calcium. In my desperation, I reached out to my dad for help. The ER doctors refused to speak to him because he was not a doctor. So my father contacted Dr. Karen Weiner at the NIH and asked if she would help. And she agreed, and so we provided the ER doctors with her personal phone number. She was waiting on the other phone at 10:30 at night. They would not talk to her because they did not know who she was. I said, Google her. It's easy enough. But they still would not listen. By now, the doctors had started giving Jocelyn morphine just to relieve her of her pain. I continued to argue and plead with the doctors to start IV calcium. They continued to disregard me. Again, I pleaded with them to call Dr. Weiner, but they refused. After 4 hours in the ER, the doctors ultimately gave up and admitted her around midnight. They told me the resident doctor would be there in the morning to develop a treatment plan. I was desperate. I knew she could not wait another 6 to 8 hours without treatment, but nobody would listen. Unfortunately, this experience has echoed throughout the community of HypoPARA. I will never forget how my daughter looked as they checked into the room that night. She was in full tetany now. Her hands and her feet were turned in, her body contorted while she lay in a fetal position. Even the morphine could not subdue her pain. With tears streaming down her eyes, her face, She asked, "Am I dying?" I was so angry and desperate for anyone to listen to me. Thankfully, the nurses saw this, and they recognized the dire situation that we were in. And they said, "What do we need to do to help?" I said, "She needs IV calcium. We need to get those levels up." And they said, "Unfortunately, without a doctor there, we cannot put the order in." And all we could do was pray for a miracle. And our prayers were answered that night. Jocelyn, without any reason whatsoever, she was able to start holding down fluids. She was able to start eating. And so with this, we were giving her anything that we could find with calcium that was in the hospital. Yogurt, Tums, milk, it didn't matter. If it had calcium in it, it was going in, and she was holding it down. This was just enough to hold us over until we seen the doctor in the morning. And after 10 hours of this, she finally got the dose, the calcium that she needed. So 2 months later, I attended my first HypoPARA conference in Chicago. During that conference, my father retired and stepped down as association president. I was overtaken by emotion as I watched member after member express their gratitude to him for this community that he created and started. To this day, I still have people coming up to me telling me, "Tell your dad thank you for what he has done." I finally understood what my dad was doing, and I decided to get involved. So over the years, Jocelyn has had multiple related calcium crashes, resulting in seizures. She takes anywhere between 4,000 and 5,000 milligrams of calcium each day just to feel normal. She continues to fight, never gives up. She's a competitive dancer. It's not easy, but we make it work. But I cannot help but wonder what this standard of care is doing to her body. Will she have significant calcification of soft tissues, cataracts, kidney failures? She's only 17 with a lifetime ahead of her. And I can only pray that she can maintain a high quality of life. The HPA is instrumental in approval of the first replacement PTH therapy in TransCon. I have personally witnessed how PTH therapy can positively affect the quality of life and how the removal of that same therapy significantly burdens and destroys quality of life. I have seen how standard of care is inefficient and leads to long-term complications, from kidney failure to calcifications of soft tissues, brain fog, kidney stones, fatigue, tetany, the list goes on and on. I could testify that each person diagnosed with HypoPARA is different. Indeed, we are like snowflakes, each unique in symptoms and severities. For years, HypoPARAthyroidism has been associated with low serum calcium levels, and the standard of care is just to treat low calcium with more calcium. This treatment is false. Low calcium is only a symptom of HypoPARA. It is the low to no parathyroid hormone in the blood. That is what needs to be treated. Hypothyroid is an endocrine disorder first and foremost and must be treated as such. And I compare it to telling a person with diabetes to manage their blood sugar by just watching what they eat and nothing else. I'm passionate because I'm not only a patient, but I'm a father and I'm also a caregiver. Thank you.
Thank you so much, Bob. All right, next up we have Katie. Katie is a post-surgical patient, so take it away.
Thank you, Patty. Good afternoon. My name is Katie Gillick, and I'm from Connecticut. I'm a state ambassador with the National Organization for Rare Disorders, and I support the HypoPARAthyroidism Association with various advocacy campaigns. I knew someday that I would be before you. I have been writing these words with my actions for over 5 years. In fact, 5 years ago today, I was in the hospital with a calcium crash. 4 years ago this month, I met the doctor who saved me. 3 years ago this June, I screened into a phase 3 clinical trial. 2 years ago this July, I met my boyfriend, who is here with me today, for a moment I thought I would be experiencing alone. On June 1st, 2018, World HypoPARAthyroidism Day, I was diagnosed with papillary thyroid carcinoma. A partial thyroidectomy led way to a completion surgery when microscopic tumor spread provided concern for infiltration to the other half of the gland. Final pathology revealed that there was no spread. This was the surgery that caused my HypoPARA. I had no thyroid and damaged parathyroid function. In terms of organ loss, I had gotten 2 for the price of 1.
I began to adjust to a life without a thyroid and fully functioning parathyroids simultaneously. That burden is vastly underestimated. At 24 years old, my life consisted of labs, 24-hour urine tests, ER visits, and going to the pharmacy multiple times per week. My cognitive function, energy levels, and kidney function suffered. My inability to retain and process information became a source of immense frustration. I was angry, sad, and scared, and I couldn't be. I was trapped in a body that could not stand to process the trauma that I had lived through because the stress of reacting emotionally was adverse to my condition. Standard of care treatment was not only not helping me, it was harming me. I visited a doctor who was an expert in this condition, and knowing the disease burden and the limitations of treatment options at the time, he told me to limp along until better options became available. Limping was not going to work for me. I worked full-time and came home at night to research my disease and to try to find solutions that would save me. I visited my treating hospitals, medical library to read the literature and to try to unearth my own cure. I created my own patient and medication summaries to give to my care team. I even applied to a career changer pre-med program, believing that I was the only person who could save myself from this disease. Then I met a doctor who said, "We're not going to leave you like this." I was accepted into a clinical trial. Within 1 month, I came off of all of my calcium, vitamin D, and magnesium. I no longer visit the pharmacy multiple times per week. I can carry on a conversation without trailing off mid-sentence, and I can access the words that I want to say. I can go to the store without a list and remember what I'm going for, where it is in the store, and how to get to the store in the first place. I work full-time, travel, and have a social life and a relationship. I get angry and sad and frustrated and scared and sick, and I withstand it. I play tournament softball in the heat of summer. I am a paralegal, and I have assisted 3 federal trials. I walk down the street in a dress and heels, carrying a backpack with 2 laptops and 6 water bottles, while rolling a briefcase behind me and carrying a stuffed file folder in one arm. I have morphed back into the woman that I once was. Diabetes without insulin. That is HypoPARA without parathyroid hormone. I attribute my success to early intervention. I had HypoPARA for 2.5 years by the time I entered my clinical trial. My kidney function has been 100% restored. My bone turnover is normal. My calcium levels are stable. My brain fog is gone. It is not perfect all the time. I still get symptoms when my body has had enough. But my capacity to tackle life's challenges has vastly expanded. Symptoms are now a cause for alarm rather than a daily burden. My quality of life has returned because of quality treatment. I have gone from having my medical issues be the center of my life to having them be a facet. That is the difference that good treatment makes. HypoPARA no longer has the power or the control. I do. I am so grateful. I dreamed of the day when my doctor and I would stand side by side to share our story, the one we lived together, to advocate as the voices that joined in unison in support of a better life for our patient community and for me. Today, that dream is realized. My doctor and my drug have helped me to create what my disease had begun to destroy: choice. I have these choices now because my disease is not choosing for me. I have reclaimed the freedom that I had lost. The drug I am on is Transcon PTH. The doctor who saved me is Dr. Michaela Rubin. We did it. Me and my doctor and my drug. One of the most precious things you can give a patient is to be heard, understood, and believed. Thank you for giving me that gift today by listening to my story.
How
Powerful words spoken, Katie. Thank you so much. All right, next up, we have Miss Lynette. She is one of our post-surgical patients as well. Lynette?
My name is Lynette. Today, March 5th, is my 9-year anniversary of living with post-surgical hypoparathyroidism. We don't celebrate this day. I never would have imagined that a cancer diagnosis would be the easy part of my medical journey. I am a person living with a rare disease that is poorly understood by the medical professionals that we must rely on to keep us healthy. I'm an educated woman with a master's degree in special education, learning disabilities. I am a wife, a mother, a grandmother, a daughter, and a sister. I have experienced 2 different medical journeys in the past 9 years. One with the standard of care of calcium and calcitrol, the other with PTH therapies of NatPara and TransCon. Trying to navigate hypoparathyroidism with the standard of care was filled with numerous emergency room visits, constant fear of calcium crashes, constant fatigue, severe anxiety, and being hospitalized for depression. Out of these events, I learned that my body does not accept calcitrol, corticosteroids. Calcitrol causes me to have severe headaches, bone and joint pain, severe anxiety, heart palpitations, unstable calcium, panic attacks, and many days that I just did not get out of bed. My endocrinologist, a series of 5 in the past 4 years, had 0 options for me. All of them promised they could help me, but every one of them could only prescribe the standard of care, calcium and calcitrol. When they figured out that the standard of care didn't work for me, they gave up on me. I tried to explain to these endocrinologists that the side effects I was having from calcitrol. Their response was, take it anyway. And I honestly tried. I researched the brands, I looked at the ingredients, and I tried Brocatrol, Tiva, generic brands, and none of them worked for me. I had the same response to them. 3 years ago, I decided to wean myself off of calcitrol. I had to choose between my quality of life and my kidneys. I chose my quality of life, hoping that a PTH therapy would be quickly approved. My endocrinologist at the time did not believe in standing orders. So I ordered renal functional panels from an online lab company and took them to Quest so I could monitor my calcium levels as I weaned off of the calcitrol. Took me 6 months, but I did it. I was on 1.25 milligrams of calcitrol, and in 6 months I was down to 0. As a result, the panic attacks stopped, the joint and bone pain went away, and the headaches ended. I had more days where I could get out of bed and function. The downside was that my body required an increased amount of calcium. I started taking calcium at 7 a.m., 9 a.m., 11 a.m., 1 p.m., 3 p.m., 5 p.m., 7 p.m., 9 p.m., 11 p.m. for a total of 18 pills or 5,994 milligrams of calcium or more a day. Taking my calcium perfectly every day did not guarantee that my calcium was stable. Every day was a guessing game. You never know what you're going to get. I took my levothyroxine at 3 a.m. for a total of 10 alarms daily, preventing me from getting a solid night's sleep. I felt like I was living on a tightrope, just like walking on a tightrope. One misstep and you fall. One missed dose of calcium could cause a calcium emergency. My medical journey with NatPara and TransCon is a much different story. I now feel like I am living on a boardwalk. I started taking TransCon through the EAP program on April 4th, 2023. I have not been in emergency room since January 13th, 2023. I'm able to go for walks, ride my bike again, play with my grandchildren, go to the grocery store. Basically, I can participate in life again. I am no longer a spectator. Instead of having 10 alarms set, I now have 2. One at 9 a.m. for my TransCon injection and one at 11:30 p.m. for my Tyrosint. My mental health has improved. I'm no longer battling depression. My anxiety is manageable by going for walks or doing yoga. I can look at my future with optimism.
Thank you, Lynette. Great job. All right, so our final two for this afternoon is a mother-daughter duo over there. And we're going to first hear from Annie. She is a pediatric patient with ADH1.
Hi, I just want to say thank you for you guys being here. It really means a lot. Your dedication to the whole organization, it means a lot. So with that being said, I'm 16 years old and I got diagnosed with ADH1 type 1 at age 10 after my mom had gotten diagnosed and got me genetically tested. The symptoms I was exhibiting I thought were normal since I have it genetically. But as I gained knowledge of the condition, I began to realize that these symptoms were not optimal and improvement was needed. The hard thing about having a genetic condition is knowing no different. Having it your whole life, you don't know what is normal or what is not. I'm an athlete, so it's hard to see my teammates who went through the same exercise I went through be affected less than me. I'm constantly asking friends or people around me if they feel things that I'm feeling just to know if it's a symptom or not. I got prescribed standard of care, which was calcium supplements and vitamin D. Standard of care was not being effective. I'd feel good in the morning, but once it became the afternoon, I'd immediately fall asleep, right after school and even on the weekends. Standard of care isn't an accurate cure because it works differently on every person and differently every day. HypoPARA is a very unpredictable condition and hard to cure. Every day, I have to figure out the best time to take my medication and where it can benefit me the best that day. If I take it too early, then I'll crash earlier in the day. But if I take it too late, then I won't feel my best the whole day. I have to make a sacrifice. It was hard to navigate how much to take also because I don't know what my level is. Getting lab results as fast as possible is what I bank on. If I take too much or too little calcium supplements, it'll possibly make me feel worse, making me go high or go low. It's a total guessing game, and it varies day to day. There are also so many outside contributing factors that medical providers try to justify my symptoms with. Maybe it's my diet, my activity level, the amount of stress I have for school, or maybe even the amount of sleep I got. I just don't know. If I tell my doctors that I'm not feeling well and I want to know what my calcium is, they tell me to go get my labs in the morning, but that doesn't fix the problem because it won't be the same level in the morning and it won't work. I want to know what it is now. Like diabetics, they're able to check their sugar levels like instantly almost, and we just aren't able to. The doctors seem to not understand that I'm still a person and not just a number on their screen. They believe that since my calcium level is normal, that I'm perfectly fine, when in actuality I'm suffering with symptoms. Even though my symptoms aren't as severe as others, I still deserve adequate treatment. I feel like I have to ask permission to treat my symptoms because I don't want to end up in renal failure. I've had kidney stones and I need to be cautious when taking extra calcium. Being kept at a low normal calcium level is not sustainable. I'm an active person and I can't live my life with low normal calcium. I'm honored to be part of a medical trial, but the treatment still isn't optimal at this stage. I'm still exhibiting symptoms and it is affecting my quality of life. Frequent blood draws deprive me of school. While being a social person, people often ask me many questions, like why do I have bruises on my arms from frequent blood draws? Why do I have to carry around my pee in a backpack while traveling to San Francisco? Like what? My hope in participating in a trial is for my data to assist further investigation for treatment. Everyone is different and deserves an adequate treatment plan that improves their condition. In conclusion, I believe various treatment options that suit this community individually can be immensely beneficial. Thank you.
Great job, Annie. Thank you so much for your bravery. All right, so Mama Jacqueline, ADH1 caregiver to Annie and a patient herself.
Good afternoon. My name is Jacqueline. When I was asked to speak, I immediately said yes, and then I got the topic of my treatment, and I laughed. I've lived most of my life without treatment, and I wasn't diagnosed until 2017 at the age of 40. Growing up, I was taught to never give up, that I have the potential to reach my goals. Work ethic and perseverance will get me anywhere I want to go. My 4 older brothers ensured that. I just need to work harder. I must not be working hard enough. A daily thought that I had for athletics, school, work, and later parenting. I was the tomboy chosen first at recess for teams. Coaches looked at me as an above-average athlete. I was an athlete. What I didn't realize was I was having severe muscle pains, body aches, and random other strange symptoms that affected all aspects of my life. No one, not even myself, knew how crappy I felt. How hard I was working on a daily basis just to have a normal life. I justified, adapted, persevered, and I had a mindset to improve what I now know were my HypoPARA symptoms. The impossible was standard of care. Like my daughter, I questioned teammates about recovery, sleep, and diet. I must be out of shape. The day came, and I was offered a D1 soccer scholarship. I turned it down. I remember I was purely exhausted. My collegiate workouts were much harder, nursing school was strenuous, and instead I had signed an ROTC scholarship. This was my life as I knew it. I had no idea I had symptoms to even report. I was an active duty Army nurse from 1998 to 2006, living the Army life. I would often joke with my soldier friends that my heart rate increased well over 100 just to get to the mailbox. When working out, my heart rate would be between 150 and 180. My arms fell asleep and my muscles cramped. Then I would just go to bed. I often had headaches lasting days or reoccurring in the afternoons for weeks on end. It must be me working all those swing shifts. I finally was seen by a provider. I reported my exhaustion, inability to concentrate, and lack of motivation. I didn't know I had other symptoms. I was treated for depression and anxiety on and off since age 23. With my pregnancies and breastfeeding, I had a relief from my silent symptoms. I often commented to my husband how I wish I could be pregnant and breastfeeding my entire life. I had no idea. I finally felt great, happy, and I had energy. In 2013, my provider suggested that I add a multivitamin with calcium to my diet. I was informed low calcium is pretty normal for women my age, as well as living in upstate New York. I was unaware I had had low documented calcium since 2002. I lived in Hawaii for 6 years. I had the symptoms. My quality of life continued to worsen, and I became more symptomatic. In 2017, while my husband was still on active duty, we moved to Tacoma, Washington. I had fought off being that patient, a wife of a physician, a nurse, and that woman who was that hypochondriac. I had reached my breaking point. I knew something more was happening, and I no longer could persevere through my silent symptoms, and I didn't know I had. I told my husband I either needed to be admitted to the psych ward or had a brain tumor. Walking upstairs was causing me to be out of breath, and my heart rate would increase to 180. I was sleeping constantly, yet waking up in the middle of the night with headaches lasting weeks. I wasn't even able to run half a mile. I had a follow-up medication check for my antidepressant scheduled. Instead, I had an EKG and labs. I was finally going to see an endocrinologist. My calcium was in the mid-6s. Finally, at 40, I was diagnosed with idiopathic HypoPARA and hypocalcemia. I had genetic testing done, and it was determined that I had the calcium sensing receptor mutation, otherwise known as ADH1. I was prescribed the standard of care of oral calcium, active vitamin D, and also hydrochlorothiazide in hopes to keep my urine calcium lower. I was told to preserve my kidneys. To preserve my kidneys, I had to keep my calcium levels as low as possible in the normal range. I was taking calcium supplements around the clock. I was taking up to 5,000 milligrams of calcium. My urine turned cloudy, and my symptoms still were there. What person would feel great living in a low normal range for anything? No one. I was on the standard of care for 6 months, and then I was prescribed NatPara. NatPara worked lovely for about 4 to 6 hours a day. Each afternoon, my symptoms would reappear, and I would just take my calcium. In 2019, the FDA recalled the NatPara. I was back to popping pills every 3 to 4 hours, waking up in the middle of the night, and being told not to take more calcium because my urine calcium was so high. I have to protect my kidneys. The current standard of care does not get me anywhere near having a reasonable quality of life. My life revolved around taking pills, blood draws, without my symptoms improving. My mind revolves around determining what I ate, how I slept, what activity possibly caused some of my symptoms. Exercising exhausted me, brain fog, I have anxiety, mood changes throughout the day, headaches, paresthesia. I was unable to work, and I was actually feeling ill from the calcium supplements. I got to the point of not reporting any of my symptoms. I know my providers care, but there was nothing else that they could do, and I know them personally. I can only compare this condition to type 1 diabetes in insulin. We have an endocrine disorder, and we have no hormone replacement like insulin. Our therapy can cause more damage than good. Our lives revolve around labs that are suitable for a normal person. We guess if we're high, we guess if we're low, we take a pill, then we wait and see how we feel. If not, and if we're wrong, we guess again. We're always trying to play catch up. I couldn't give up and accept my physical or mental state. Many do with this condition. I had to become my and my daughter's advocate for managing and treating the low calcium. I sought out medical trials to participate in to advance any treatment for the HypoPARA community. I attended the HypoPARA Association conference in Denver in 2019, and that's when I started my outreach for possible trial opportunities. 2 years later, 30 minutes apart, I was presented the opportunity to be in 2 different trials. I had hit the jackpot. Now to make the decision. I ultimately chose the trial that I believe would not only help myself in my quality of life, but more importantly, assist the entire HypoPARA community of children that should never, ever have to experience hypocalcemia symptoms. The trial medication is not perfect, but I no longer suffer with daily endless symptoms. My quality of life has drastically improved. But what if there could be more? What if it could be better? The more medications and treatment options providers have to assist in optimizing everyone's quality of life needs to be done. I'm grateful that there are options on the horizon. This needs to continue. Our children deserve it.
Oh my goodness, that was wonderful, sharing all those different stories with us. And really, thank you all for putting it all out there and doing that. So let's give it up again for the panelists. We heard a lot about people that are on standard of care. We've heard about people that were on clinical trials and the difference, and some hopefulness and maybe some hopelessness if they aren't on it. So we really do thank you guys for all of that. So we're going to go into now to 3 different polling questions. So if you could get your devices ready. Our first polling question is, what medications or medical treatments have you or your loved one used currently or previously to treat symptoms associated with HypoPARA? Please select all that apply. A, calcium supplements. B, calcitrol, rocaltrol. C, Forteo. D, not para. E, clinical trial medication. F, magnesium. G, potassium. H, vitamin D2. I, hydrochlorothiazide. J, other. Or K, you've not used medications or medical treatments recently. All right, the calcium's off the chart, right? Lots of calcium there. Calcitrol, rocaltrol. Magnesium goes up there too. Vitamin D2, hydrochlorothiazide, absolutely. We have a few on Forteo. We have a few on clinical trial. And then we have some on other. Okay. The next polling question is, how well does your current treatment regimen treat the most significant symptoms of HypoPARA? A, not at all. B, very little. C, somewhat. D, to great extent. E, not applicable because you're not using anything. All right, so we feel that our current treatment is somewhat helping. And some feel that to a great extent. Good. Very good. All right, moving along to the next one. What are the biggest drawbacks of you and your loved one's current treatments? And we want you to select 3. A, not very effective at treating target symptom. B, only treats some but not all of the symptoms. C, limited availability or accessibility. D, side effects. E, route of administration, how it's taken. F, requires too much effort and or time commitment. G, other. And H, not applicable, not using any treatments. The biggest drawbacks, selecting 3. As suspected, only treats some, but not all of the symptoms. It rates the highest. The side effects, which could be long-term effects as well. Limited availability or accessibility in some cases. And people feel that it is not very effective at treating the target symptom. Okay. Good. Thank you all for participating in those polls. Now, we want to elaborate a little bit more on this. So I want to ask, based on your current treatment, and again, this is open to patients and caregivers. Certainly, you can speak for your patients as well. How do you feel on your current treatment? How do you feel on the current treatment that you're currently using? Who would like to share? Go ahead, Caroline.
So my current treatment is I'm using 1.25 micrograms of Forteo delivered every hour through an insulin pump. And it's the best decision I've ever made for myself. It was a little bit of time and effort to get things dialed in, but I can go do a CrossFit workout. I can take care of a severe calcium crash at home without an emergency room or IV calcium. The biggest problem I have with it is the fact that both the Forteo and the pump are off-label, and so I'm at the mercy of my insurance company for whether they will cover it or not. And I spend about 100 to 150 hours a year fighting with my insurance company to keep this. But the medication itself and the delivery system is glorious.
Good. Thank you so much. Andrew?
Yeah, I'm on standard of care. I would say that when I'm optimal, I still feel horrible. For those of you that are genetic, you feel terrible. You just don't know it. I function, I go to work, but it's a lot of maintenance. I eat the same food. I think before this conference, my 11-year-old daughter and I sat down and calculated how many mozzarella pearls I've eaten, and it's close to 31,000 because I eat 12 a day. Everything I put in my body is more powerful medicine than the standard of care. The sports drinks, the protein drinks, the potatoes I eat, you know, managing the phosphorus. All I want out of life is a hot dog and like a sandwich from Jimmy John's, and I can't do it because it's not in my diet. And so I would say I've figured out how to just maintain, not miss work. I'm there for my people. I'm there for my kids, but it's infiltrated every aspect of our life. You know, recruitment dinners, is there gonna be something I can eat? How much extra do I have to take? And it's all just a guessing game. And so there it is. That's me.
All right, thank you so much, Andrea.
It's just survival.
Michelle, comments online?
Yes, so I have one that says, I'm on Forteo on a pump, but I'm still not able to work or do daily chores, so it's not optimal for me. I have one that says they are in the HypoPARA SUP program, and while it's not optimal, it has decreased their hospitalizations by less than half, but they're still hospitalized every month. But they are on HypoPARA on the pump as well. And then I have several that are talking about standard of care and how they really don't feel like that it's doing anything other than causing them to have to set alarms all day long.
All right, thank you so much. All right, and is there anybody, go ahead, Bob.
Yeah, again, it is such a unique experience from my perspective, right? I've talked to a lot of patients doing this advocacy work over the years, and I yes, as a genetic patient, I guess for me, numb might be a way of saying how I feel a lot of the times. You know, you just don't know. And Annie is absolutely right. As a genetic patient, you know, this is just, I don't know what a normal is. I don't have a baseline. And honestly, I didn't even think about that till this last conference, believe it or not, when Michelle looked at me and we were talking about maybe joining the Calypso study. So we're still waiting to see if Dr. Clark comes back from that. But I really, my heart goes out to all you surgical patients. I cannot imagine going into an operation one day with working parathyroids and then coming home the next day, or the next day you wake up in the morning and you have nothing. I mean, the shock that you guys have on your body, what that's got to do, blows my mind. I wouldn't even want to even live in a day in your guys' life. I might not know, but this is my normal. You guys have a normal. You know what you're missing. And that's probably the hardest part about what you guys are going through, is knowing what you once had and knowing that it's not achievable, at least not yet. And that's why we're here, right, is trying to get that achievable again. And so my heart goes out to you guys, the surgical patients. It really does. It really absolutely does. I see what you guys are going through, and my heart breaks for you.
Thank you, Bob. Sherry?
Can you repeat your actual question, your wording, Patty?
So with the current treatment, how do you feel?
So my current treatment, I am on HypoPARA through the special use program. And personally, every day is scary. It's one of those things that with me, I have the, I don't know if I'd call it a blessing or not, but be able to see 32 years of treatment as to what it was when it's just standard of care with oral meds only and all, you know, through the whole range. But unfortunately, I don't have the option of going back. So with the HypoPARA recall happening, I know a lot of people are talking about, oh, I don't want to have to go back to using just orals. And with me, at age 23, my body stopped absorbing most of the orals. So I personally, the way I feel on a regular day is you know, horrible, just like everybody else here. But it's one of those situations that I don't have the option of going backwards to relying on that. So my option became, when I stopped absorbing orals, that's when I started to need IVs through a port every other day for 8 hours a day. And then it got, you know, spread out from there, but I can't go backwards. So my backwards, with the recall happening, would be back in a hospital room permanently. I mean, IVs is the only way for my body to absorb it. So it's scary. It's scary when there isn't another option out there. So, and when I was on Forteo, prior to the HypoPARA, I was needing up to 9 injections a day of Forteo. So I was using 9 full Forteo pens, and it still wasn't enough to last my body throughout an entire 24-hour period. So I don't have an option to go back to standard of care, and so a recall is terrifying, and having another option would be literally life-saving.
All right, thank you, Sherry. And Katie is over here. Oh, here. Oh, Michael.
Thanks. Yes, Michael again. I've been on the standard of care for about the last 14 years. My request to be admitted to some of the Forteo and other options was declined by my insurance company on the grounds that my symptoms were being managed relatively well within the normal levels with calcium and calcitriol. As I've said, I think because I live a fairly thankfully for now, active, normal life, the doctors have basically said, we can support your request, but it's going to be hard to get the backing for the synthetic hormone replacement therapies until more are available on the market. My concern has always been not the near-term acute impacts of the standard of care, but the long-term chronic impacts of the standard of care. And I already mentioned kidneys, and renal function is clearly a concern for many patients. I would have to also acknowledge the shorter-term unpleasantries of constipation and other issues of taking large amounts of calcium all day long. Obviously, I think those are quality of life issues, not so much imminent acute threats, but they're the things that you have to deal with decade over decade, and doesn't make it something you want to look forward to. So the standard of care has met my immediate needs, but not the long-term chronic needs.
Thank you. Thank you, Michael. Miranda, and then we're going to go back to Valerie. Miranda? John? Or? Nope. Nope.
Nope.
Thank you. I'm currently in a clinical trial. I'm in the Calypso trial, and in many ways it's been life-changing for me. I've never been on any other PTH. I've been on standard of care the rest of the time. But I will say it's not perfect with any, I think clinical trial, it's a learning thing. And what I find is if I could keep my life exactly the same, I feel like I could keep my calcium exactly the same. But what's hard is my life is not the same. I envy Andrea that can have the same diet and all those things. I am not that great at those things, and my kids still wake me up in the middle of the night and we get sick and all those things, and my calcium still seems to fluctuate. But I am so grateful that clinical trials exist, because it has in many ways been life-changing for me and restored my kidney function and some of those things that you worry about long-term with standard of care. And so, yeah, that's my experience.
Thank you. Thank you, Miranda. All right, Valerie.
Hi, I'm Valerie. I'm from Virginia. I'm so glad this is local and I could come and to see old friends. I'm going to say I'm living in La La Land. I've just I've figured out my new normal. I had cancer 4 years ago, and you know how hospitals work. And they put me on calcium carbonate, and they put me on magnesium oxide, and I've just stayed with that. And I've been real consistent since all that went away. And anyway, I've been real consistent. I make sure I don't try to run. I don't do any additional exercise that I used to do. I walk, I hike, I do old lady exercise classes, so I can handle that. But I say I'm in La La Land because I have a great endocrinologist that believes that 9.5 is okay. So I have high calcium, so I could do all this stuff. He doesn't believe in testing my urine, my 24-hour urine calcium, because I'm showing no signs of kidney disease. And I'm like, wee, yay. I hated doing those. So I know I'm in La La Land. I live in a great state of denial because I forget to test my, or to look at my oxalates and not eat chocolate till I see old friends that remind me that I'm not supposed to be eating those. So I therefore, I'm reminded here again, and I live in fear of dying young before my 20-year-old daughter can really enjoy me, give me grandchildren, and all that stuff. So thank you.
Thank you, Valerie. Michelle, I'm going to come back to you one more time, and then we're going to get you.
Okay. I have a patient online that is taking 9,000 milligrams of calcium a day with seeing little effect, has never been able to achieve a calcium over 7.4. Another patient who was on HypoPARA, and then since the recall has been on calcium and calcitriol again, and knows what it feels like to have their life back and then ripped away from them again. Another one using calcitriol and calcium and does not relieve any of their symptoms. And we have a patient that also said that they were not stable on standard of care, being hospitalized several times a month, now are resorted to getting IV calcium daily.
Okay, thank you. All right, ready?
Hi, everybody. I'm John. I'd just like to say from what I've seen today, and I have to share, first of all, I'm post-surgical for a long time. I've had recurring kidney stones, a lot of tetany, and it's like that balance between stones and tetany I'm always on. But the biggest factor I'd like to talk about, what I've seen here, is that the definition of fog, it means you can't see far ahead. So there's so many leaders here, there's mothers, there are other leaders, and you take away their ability to look ahead. If you're a leader of a group, you're not only looking out for yourself, but you're looking out for everybody else. Now, how do you look ahead if you're in fog? And that's probably the most debilitating, and one of the reasons I retired early. I couldn't keep up with these young people I had to lead. So I think, from what I've heard, these studies can make a big difference in lives, and I look forward to that. It reminds me in a way, when I was diagnosed with cancer, I was hypothyroid, and when I got out of Synthroid, suddenly I had that jump again. I'm sure all the post-surgicals can relate to that you felt back good a little bit again. And I'm hoping that these studies can do that for us, and especially the clarity and lack of fog. That'd be great. So, thank you.
Thank you, John. All right, so we're going to do one more poll this afternoon, and then I'm going to ask a question of the audience again. All right, so short of a complete cure, what are the top 3 specific things you would look for in an ideal treatment for HypoPARA? Top 3. A, improve cognition, brain fog. B, improve stamina, ability to do daily activities. C, less muscle and joint pain. D, improved ability for self-care. E, improved sleep. F, reduction in urine calcium levels. G, reduction in kidney stones. Or H is other. So short of a complete cure. All right, looks like improved stamina and ability to do daily exercise. It's hard to just stay stagnant. Improved cognition is the second. Less muscle and joint pain. Then reduction in urine calcium levels as fear of the future for your kidneys. All right. So again, improved stamina and ability to do daily activities came out top, muscle and joint pain, improved cognition, brain fog, right? We've talked about that a lot today. So we have a captive audience. We have FDA, we have pharma, we have researchers, clinicians here. What would be the one thing that you would want to share with them that would improve your life as a HPA patient? Or caregivers, you're welcome to share as well. And we're going to go back here first, and then we'll come up front, and then to Michelle.
My name's Emily. I'm about 5 years post-surgical, and I've been fortunate that I've only had one emergency room visit, 2 years of a lot of specialist appointments and trying to figure things out, and a lot of different medications. I'd say I am fairly stable, but I think you get used to the new normal. The ability to not be able to self-monitor is the biggest thing for me, because I can be feeling good for a stretch of time, and then something will happen in life or in my body, an illness, then you go down for a while. I recently had a stomach virus and thought, oh, I'm dehydrated. I think my calcium levels are too high, heart palpitations, those kinds of things. It's going to resolve once I'm hydrated again, better hydrated. I just had my quarterly labs and I was totally wrong. I'm low calcium and my thyroid's off. So it's just not being able to know in a day, or as maybe someone with diabetes can test and know, do I need to take more calcium or less calcium? Because doing the wrong thing can really make you feel that much more awful. So.
Absolutely. Thank you so much for sharing. Andrew?
So I think for me, having space available in my life to be able to take the meds with hours in between them, I'm so regimented in everything that I eat, everything I put in my body, and when I take my medication, that I'm now having trouble absorbing copper, of all things. And so 5 days a month, I go for a 3-hour infusion, and that's become my new normal. And so by getting HypoPARA under control, I've caused other issues within my body by being so rigid. So while I would love to get rid of the brain fog, that would probably be my next, just having the ability to eat freely and take medication more spaced out so that I don't cause unintended consequences, that would be huge for me.
Very good. Thank you so much. I'm going to go to Michelle, and then I'm going to come here. Michelle, do some comments online, then we're going to go to Caroline.
Okay, I have one that says, the disease already causes fatigue, but when you have to get up constantly throughout the night to take pills around the clock, it just adds to the fatigue. So I would like a treatment that doesn't require me to take pills around the clock. Another one online is saying that uninterrupted sleep because of my treatments. And then several people talking about the need to test in order to know that even if I am remanded to staying on standard of care, I need to know how to be able to adjust that standard of care.
Very good. Thank you. And Caroline?
I think one of the things we really need is the ability to do customized care. NetPara was great, but there were only 4 doses. And so if you didn't fit into one of their 4 doses, it was really difficult. You know, you take one dose and you're hyper and everything's a mess, and you take one dose lower and you're hypo and everything's a mess. And we're so variable. We aren't 4 categories. And so we critically need the ability to do customized doses based on our own personal experiences and levels. You know, that's one of the things that, you know, we keep going back to type 1 diabetes, but, you know, the diabetics have the ability to do a truly customized insulin delivery decision. You know, they can do levels, you know, they have the ability to test and then give a specific amount of insulin based on what their levels are. And something like that would be really nice. And that's what I've been trying to mimic with my pod and my standing stat orders. But the fact that I have to drive 15 minutes, and I'm lucky, it's only 15 minutes, but I have to drive 15 minutes down to a lab. I have, you know, and then I have to wait another 20 minutes. And I'm really lucky and privileged that it's only 20 minutes to get my standing stat orders back. But I still have to wait 30 minutes, and then I can make a treatment decision. But to have that ability to see our levels and then be able to respond with a hormone treatment and a hormone replacement rather than a calcium replacement would be, it's life-changing that I can do that. And I wish everybody in this community had that same opportunity.
Thank you, Andrea. Or Caroline. All right, Katie. Either way.
All 3 of us.
Yep, there you go.
Go down the line again. I remember having a very stark realization after I was diagnosed, and kind of towards what others were saying previously. I realized that I had essentially become a diabetic overnight when I learned that this condition was not adequately controlled based on my experience with calcium, and that the next available option for me was an injection. And as soon as my doctor earlier on in my treatment had said injection, she meant Natpara, and this was while it was still on the market. And I panicked because I just had this realization that my life was completely altered, and I was very averse to that course of treatment. I didn't want to accept that that is really what had happened to me. And then as the months wore on and I began to see other aspects of my health suffer, I realized that it was worth considering. And after consulting with my care team, I'm so grateful that I did decide to pursue that option, because so many of our patients, as you continuously hear throughout the day, we're all saying the same thing, right? Standard of care is not enough. Standard of care is harmful. Here are all the things that are happening to me or that could happen to me. And I was very afraid of all of that. And I'm very, just once again, I'm very grateful that I received intervention early and that I've had such success with that. And I truly believe that that intervention early in my disease has helped me to recover. And I would be terrified to lose the progress that I've gained. And so I urge all the appropriate parties to take what you hear today from all of us, and please give us the credence that we're asking, because I stand before you telling you that my life has changed because of the drug that I was urged to consider, and I'm very grateful.
Thank you, Katie. Who won?
I would say piggyback on the online viewer, self-testing. Home testing, if we could get a kit where we can test our calcium at home and not have to wait for the labs to come back. While we're in the wait, we're becoming extremely critical, which is ending us up in a hospital. I remember a time I was once in a hospital and I had maybe 8 rounds of infusions, and they actually switched me over to the standard care because they wanted to know I would be okay if they were to discharge me, that I can maintain just on the standard care. But when they would switch me over to my oral medications, I would crash like instantly every time. So it kept me in a hospital longer, right? And I'm like, why don't I just pull the pole with me and strap the IV, And if that were an option for me, right, because I had been on Natpara before, even with Natpara, what about those people that are not, don't respond well even to, the trial drugs, which is, in my case, what do we do next, right? And so we certainly can't wait for that patient to sit there and die, right, in the hospital. They're not responding to standard treatment. We're not responding to the drugs that, trial medication. So then what does that person do? What do we tell our families? What do we tell our children, right? So I would like to see more, self-testing. That wait period is really critical. So while we're waiting, that could be minutes, seconds, hours off our lives, So that's all I'm going to say.
Thank you, Tisha. Very good. All right, Bob?
Yeah, so I'm not on a clinical trial. I've seen people on clinical trials. I see my dad was on Natpara. He did really well on that till he got taken off. I've seen positive and negative effects of being on and off of those hormones. But what I think, going back to the question, is what do we want the industry leaders to know, the researchers and the doctors to know? We've heard a lot today. The word that keeps coming to my mind is normal, my normal. I want you to understand that it might be our normal, but it's not right. And the more the research is done on the doctor's levels, this last conference we were at, Dr. Khan mentioned in her presentation, she goes, and I never even thought of it like this, but she goes, PTH is found to be in every organ in the body. And I think as we go do more and more research and we find out exactly how the PTH is entwined in the body, that's going to really tell us how to treat these symptoms. And that's why we're so different, is because we're just beginning to understand what exactly we're dealing with. And I am so grateful for the pharmaceutical companies coming in with these therapies and giving us options. And I'm thankful for the doctors doing the research and doing the studies and trying to figure out what exactly is going on. And even the FDA. I want to thank you guys for making sure that what is coming out is safe and effective for us as patients, right? But when we talk about normal, it doesn't mean that we're okay. It just, this is my normal. And I'm suffering. You just don't know it, and we're really good at hiding it. So this isn't, the thing that really need to take away from all of this is that this is not a calcium game. Calcium, again, first and foremost, is a symptom of low PTH, low parathyroid hormone. And until we figure out that piece of the puzzle, we're going to continue to suffer, and we're going to continue to struggle, and we're going to continue to have people say, this is my normal. And we want to get to a point where our normal is actually good, and we feel good.
Absolutely.
So.
Thank you, Bob. Wait, here, and then we're going to go to Annie.
Okay. I just wanted to speak to the, I guess, provider part, and just validation is everything. So many times our labs are not going to explain our symptoms, and the listening, sometimes just listening and validating what we have to say, you'll never know how important that is to us, because we encounter a lot of people that don't do that. We have a saying, whatever phrase at the hospital I work at, and it's like, know me, care for me, and ease my way. And even if you don't understand or you can't explain why our lab values don't equal our symptoms, just validating where we're at is so helpful.
Absolutely. Thank you, Miranda. All right, and Miss Annie.
Going back to like what I want in a treatment, I just want a treatment that works. Like, there's so many options that just don't work and like don't get rid of like my symptoms completely and like most people's symptoms. Like, I don't know, the treatments that people are on, like in standard of care or trial drugs, like, yeah, they decrease the symptoms a little bit, but we're still experiencing multiple symptoms, and it's definitely degrading our life. And I just want a drug that like works all day, and like I don't have a drop or like a crash or anything. I just want a drug that like works all day and like works on everyone, but like various drugs to fit into everyone individually, because like one's not going to help everyone. I just want multiple options.
Thank you, Annie. All right, Sherry, and then we'll go back to.
Again, going back to the question, just the one kind of takeaway with everybody here from, FDA and everywhere, all of the sponsors. Again, thank you, obviously, on all of our behalf. You'll have no idea how amazing it feels as a patient to see how far things have come. And Bob, I know, I'll say it, where your dad started with the HypoPARA Association, and starting back where there were only a handful of people at that very first conference, and to now see where we are today and how much work went into even putting this meeting together. It takes a lot, and on behalf of all the patients, I would not only like to thank all of you for coming, but Patty and Michelle and everybody in the HypoPARA Association in general. Thank you very, very much.
Thank you.
And the last thing is, I would say, is if you guys felt in any way today, clearly we all did, I want you to think about those feelings that you heard as you heard all of our stories today. If that one that touched you, or that one that you were just like, oh man, I can't imagine, or which clearly happened a lot today, remember that feeling. Because once you guys return to work and you guys go to the next patient, you go to your next thing, you go to your next, we're still here. We're still dealing with it. And we've spent our whole lives in some of our cases being forgotten and being overlooked. So as much as we appreciate your time today, which is immensely amazing and a beautiful, beautiful thing, don't don't forget about us, and don't forget that we're here, and we truly appreciate what you do. And tell your coworkers, tell whatever, keep the HypoPARA, word out there, and get it out there, because that's how we got here. So I can only imagine, hopefully, where we can be in 10, 20 years from now.
Thank you, Sherry. Thank you so much. One in the back? Here.
My name is Alex. I want to add a little to what Tisha said, that we need some kind of home kit for testing calcium. And at previous conference, chemist from Richmond Medical School said that a blood test still is imprecise. It's difficult to reach necessary precision. But he said urine could be extremely easy to do. Why not to make a home kit for measuring 24-hour urine test? Yeah, I myself, I don't have a long time yet after surgery, like 2 years. And my symptoms mild, like already was mentioned by other people. But we know where it all goes. If you lose some function, sooner or later, you will have all this bunch of calcifications everywhere, kidneys, brain, and yeah, so without replacement, of course, prospects are clear. It only takes time. If you use traditional therapy, calcium, big doses, definitely most people have problems with kidneys. I already have some, I see by diastolic pressure it is becoming higher. It means that kidneys are struggling maybe. So yeah, replacement probably would be the only good answer.
All right, thank you, Alex. We're going to go to Amelia, and then we'll go in the back there.
Okay, kind of piggybacking off of what Tisha and Annie said is everybody that I've talked to today since yesterday, everybody that I've met with HypoPARA crashes and has different reactions to different levels of calcium, yeah. And a way that we could test at home or more accessible, faster results would highly be appreciated, because we all have different levels, and it's not, oh, one level is the same thing for all of us here. So that would be amazing, and yeah.
Thank you. Thank you, Amelia. All right, one more in the back, Anna.
I'm thinking about the presentation earlier by the doctor. It seems like the one area where the current drugs still can't address is keeping your levels stable. And I've learned a lot today. I've never had a crash, but it's horrifying to hear about these stories. And so it looks like getting the levels stable is where the pharmaceutical companies need to put their dollars. And the other second comment I had is I feel like we're in a little bit of a chicken and egg situation, because until a drug is marketed, we just don't have enough data to work with, right? Right now we're working with the few, there was the Naptera study done, but the trials are small, so you don't have a lot. I am a scientist as well. You don't have a lot of data points to work with, but once a drug is marketed, then all of a sudden you have thousands of data points, and that can allow the pharmaceutical companies to improve over that. So I think we just need to get over this hump of getting something on the market that, of course, is safe, so we can move forward as a community. Anyway,
Thank you so much, Anna. All right, I'm going to go to Joanne. And what you would be looking for with HypoPARA, if we could do something.
I'm sorry, I'm going off subject.
Okay.
I'd like to know, before I boarded that plane yesterday, I had my calcium checked. How many others before they left were able to check their calcium?
Yeah, so I think what we probably ought to do is put that in our comments section, and then we can have people reply to it, and then we can all see the comments for that. because we are having to get
Okay.
things closed out. But that's a really great question. I think
Yeah,
it would be
because-
great to be in the voice of patient as well.
After the traveling and being here and all the conversation, obviously, I would imagine most of us are having symptoms right now.
To a degree,
Yeah.
yes. Yes. All right, thank you. Julia?
Yeah, I'll speak quickly. Having had my stomach removed from cancer, there are others with APS type 1 that have malabsorption, so we would like a medication that would bypass the gut. Injections are great because they bypass the gut. So having an option for those of us that cannot absorb medications, even if it is given in mega doses, would be great as well.
Okay, thank you very much. Okay, Michelle?
I have one online that says the one thing that they would like to make their life better is better research. Being told constantly that their symptoms are not hypopara, but then going in the patient groups and seeing everybody saying that they're having the same symptoms, so more research. And then, I gotta find the one again, sorry. I'm gonna share, there's several on here that talk about the calcium monitor, but I'm gonna share this one because it's a little humor for the afternoon. Being able to test my levels would be game-changing. They can test cows, why can they not test us?
There you go. All right. Okay, so reminder that we're going to have our comments open for the next 30 days. So even people that have participated here, you're certainly welcome to go on. You can add. I think there'll be some good conversation around that. So I just want to do a little recap as we close up today. And before I do that, I really just want to thank, if I could have all the panelists just stand up, and we need to give you a great big round of applause to say thank you. You did an absolutely amazing job. Thank you so much. So I'm going to take the next couple of minutes and just recap us for the day. So we heard so many stories of the daily struggles and burdens for patients living with HypoPARA. We've also heard from others on how this affects them as caregivers, family, and friends. We heard about the physical aspects of HypoPARA along with the emotional and mental effects of HypoPARA. I am sure anybody listening had to feel the severity of how this disorder affects the lives of patients on a daily basis. Over and over again, we heard similar stories as Kim remarked. The current standard of care is insufficient, ineffective, and unsustainable. Bob also added that the standard of care is insufficient and leads to long-term complications. Imagine right now if you had to set 6, 8, 10 alarms on your phone over the next 24 hours, and you had to live by these alarms no matter what you were doing, swallow down a handful of pills each time. Can you imagine this as your everyday life and you still didn't feel good? Imagine swallowing those pills down, not knowing that taking all these pills will lead to kidney stones, brain calcifications, arterial calcifications, but the pills you have to take to keep your heart beating and your other organs functioning and to have somewhat of a cognitive function. Imagine all this. This is the life of a HypoPARA patient. Carolyn shared the inability of patients to stabilize on oral medications is a stark reminder that this is in fact an endocrine disorder most similar to type 1 diabetes in the severity, the blood level, the volatility, and complexity of treatment, yet we still don't have an approved treatment. Bob commented for decades, HypoPARA has been associated with low serum calcium levels, and it has been said that we only need to treat for that. That statement is false. Low calcium is only one symptom, and taking calcium does not fix your PTH levels. HypoPARA is an endocrine disorder first and foremost and must be treated as such. HypoPARA is the only endocrine disorder that does not have an FDA-approved hormone replacement option available, and our health reflects this. Lynette shared that every one of her doctors would prescribe standard of care, calcium, calcitrol, and as soon as they figured out that it didn't work for her, they would give up on her. Imagine right now being in the doctor's office and the doctor had no other choices of medications to help you with. Would you think you were just left to die? Amelia, our 14-year-old patient, shared that she had been diagnosed for 4 or 5 years, and that might not seem like a lot, but she didn't remember life outside of taking pills every morning. Can you imagine this for your 14-year-old child? We need more clinical trials for patients who desperately need help and hope. These trials cannot require the patient to wash out. As Caroline had mentioned, she would not have made it through that period, which left her no options. We need options. Jacqueline, living with ADH1 for 40 years and not being diagnosed, reminded us that she always has severe muscle pains, aches, and random strange other symptoms. No one knew how crappy she felt. She didn't even know how miserable she was. There are so many others out there that don't know or are not diagnosed because somewhere in their life, a doctor chose not to do more tests. They chose not to dig a little deeper and just said, take some Tums. We need more education for clinicians to help diagnose and treat the patients. We need more researchers to understand the effects on daily lives and dig deeper to understand this complex endocrine disorder. We need more pharma to be willing to develop treatments, and we need urgent solutions. We need urgent approvals, and we need hope for a better future for all hypoparathyroidism patients. To all of our HypoPARA warriors out there, keep faith, keep pushing through, and we're going to all keep advocating for a better future. Thank you all for attending. We appreciate you, and have a great rest of the day. Thank you.